the name of Allah, the most gracious, the most beneficious, we are truly honored to host many nations, many brothers and sisters from around the world. Welcome to the 7th International World Islamic Health Union meeting. Thank you, welcome. First thing first, we will start with the most important thing in our life, Quran Kareem. And I would like to invite my dear brother that you all would really feel that he has a great voice, inshallah. Seyfettin Yeniçeri from Milli Eğitim Bakanlığı, Beşevler Kampüs Cami İmam Hatibi. Çok kıymetli Seyfettin Yeniçeri Beyefendi, Milli Eğitim Bakanlığı'ndan Beşevler Kampüs Cami İmam Hatibi'ne Kur'an-ı Kerim'i
I would like to invite him for a Quran recitation.
Hoş geldiniz.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين بسم الله الرحمن الرحيم وقل رب أدخلني مدخل صدق وأخرجني مخرج صدق واجعل لي من لدنك سلطانا نصيرا وننزل من القرآن ما هو شفاء ورحمة للمؤمنين ولا يزيد الظالمين ولا يزيد الظالمين واعلموا أنما أموالكم وأولادكم فتنة وأن الله عنده أجر ويكفر عنكم سيئاتكم ويغفر لكم والله ذو الفضل العظيم. بسم الله الرحمن الرحيم والعصر إن الإنسان في خسر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. الله أكبر. صدق الله العظيم. الفاتحة.
Yüreğinize sağlık. Allah razı olsun. Kıymetli hocam, hepimizi etkilediniz. Çok teşekkür ediyorum.
Thank you very much. It was really impressive. If you do not have headphones for interpretation, you can take your headphones right outside.
An actual headset to get out and take an headset. We'll wait for you. So at least you'll have simultaneous opportunity because many of our presenters here will be in Turkish. Yabancı dilde olanlar
I made the announcement for the English-speaking participants, and we will have a reward ceremony. I will continue in Turkish, and we will continue once everyone has taken their headphones. So I would like to welcome you all to the 7th World Muslim Health Societies Congress and Fair. Dr. Khamis-American, the chair, chair, and Professor Dr. Doğan, Ünal, and also specialist Dr. Abdullatif Faslı, and I would like to thank them all and all the others who have contributed for the organization. Now I would like to invite Professor Dr. Doğan Ünal, the Congress chair. The floor is yours, Congress chair. In the name of Allah, the participants, distinguished participants of the protocols, and our dear guests in the venue and online. In different parts of the world, there are health-themed NGOs, and our organization is composed of these institutions and organizations. I would like to welcome all to 7th World Muslim Health Societies Congress and Fair. Previously, we had our congresses and fairs and the topics of migrant health or other issues, and this year we will have oncology. Oncology and social problems of oncologic patients and integrated care topics will be discussed, and also we will talk about the components of oncology which are indispensable, and all these topics will be discussed in a live and efficient environment, and we will discuss them with competent people. Yes, we designated our topic as oncology because we know that oncology has quite important impacts on institutes, states, and governments, and also it has many neglected gaps which should be filled out by the civil society. We are talking about the health literacy, and oncology is one of the fields where we need health literacy because there are some people who are trading with people's hopes, and we can have negative health issues, problems, and we now have some improved technologies, but there are also some other material and spiritual needs of the patients and the patient relatives. And in order to underline this perspective and in order to put that in our agenda, we decided to discuss oncology, and we invited about 400 participants from different parts of the world, and then from Turkey. I would like to thank those who have contributed for the organizing of this Congress. I would like to thank Dr. Khamis-American and also those who have taken responsibility in all parts of the society, and I would like to thank all the academicians and also firms and institutions who provided financial support. And of course, I would like to thank you, our participants, for your participation. I wish you a beneficial Congress. Welcome again. We would like to thank Professor Dr. Doğan Ünal, the Congress chair. Now, I would like to invite Devlet, Sert, Secretary General of Sağlık İş Union, Trade Union. I would like to invite him for his greeting speech. Distinguished participants, distinguished dear guests, this is the 7th World Muslim Health Societies Congress. And now we have guests from all around the world, and it is quite I'm quite glad to see all those people from different corners of the world, and I'm really happy to be invited as a participant and also to be invited to make a speech in the opening session. Is quite gladdening for me, and we got quite excited because we are also the host of this event. The seventh world. I hope that the Seventh World Muslim Health Societies Congress will be beneficial for all components of the Congress, our societies which are working for the Muslim people and all institutions, all participants. I wish that this is beneficial. The world has seen many statesmen, and we also have, but we always commemorate our old Prime Minister, the late Necmettin Erbakan, was really important for us. He considered the problems, issues of the society, his own problems, and we established this Sağlık there in 1991 on his orders, and our current president Recep Tayyip Erdoğan is also supporting us, and we have now international strength, and we are trying to increase awareness in the field of health. And when we think about their efforts and their approaches towards Ummah world, I would like to extend my gratitude to Kasım Sezer, and I would like to thank him for his efforts. As a Sağlık trade union, we have 200,000 members, and we are an example to the different institutions in the world. We are the backbone of this society, of this structures, and we continue providing services. In recent years, there have been successful policies in the healthcare services, and we have understood it better during the pandemic process. And the devotion of the healthcare officials were appreciated, and it was quite happy. We were quite happy to see that. And the healthcare officials are conscience servers. They serve for the conscience, and they they're there to serve people, serve society, and healthcare workers are not just only serving for their own society or people. They're also bringing a breath and remedies to the other Muslim societies, and they work hand in hand with Ummah. We as trade unions are the largest NGOs in our countries, or among the largest NGOs in our countries, and we have our responsibilities, and we need to enshrine these values. And for this reason, I would like to thank Kasım Sezen. When he was establishing this society, he invited us as a founding member, and we didn't hesitate even just for a second. And we know that these problems are the world's problems are as important as our own problems in terms of health care. And anywhere in the world, no country. Every country should receive help when they are in need. And in healthcare services, we need to fulfill our responsibility about those who are not able to reach their needs. And in order to protect our values, we should continue working day on and night. For this reason, we have two water wells, and we tried to resolve the drought issue for the children in Africa, and we tried to bring water to them. And in Gaza, we worked together. We heard the call of disabled, orphaned children, and for their rehabilitation, we provided support to them, and on behalf of the workers of health and social workers, health workers and social workers, we are building a center for them. Distinguished participants, we have a different approach towards trade unions. We're not just collecting the membership fees, and we're not just focusing on bargainings. Of course, we fulfill our roles and responsibilities as a trade union, but now we have a different and next generation trade union approach. We continue our path with that in mind, but we also have something which is neglected by the universal or international trade union approach. We have our confederation Hakish, as it's stated in its principles. We hold our values and beliefs dearly, and we are leaving our traces, and we are trying to be role models for this society. And while we're doing all this, we are trying to we were trying to exert our efforts for the labor, but we are sharing this world with other Muslim brothers and sisters, and we cannot neglect them. We are trying to support them, help them, and we are doing this under the umbrella of Sağlık and also international organizations, societies. Distinguished participants, every year we gather under a different main topic, and this year it is cancer. And millions of people every year lose their lives because of this disease, and sometimes the science of medicine and healthcare workers have nothing to do. And in Turkey and in other parts of the world, there are new technologies, treatments, cures, medications, and with the great efforts of the healthcare officials, we provide remedy to those people. We are talking about the protective healthcare services, sustainable healthcare services, and complementary healthcare services, and these are different stages, but at the focus there is always people. And this successful journey has labor at its heart. And today we will have scientific studies and presentations, and I hope that they will provide us with new hopes and new horizons. I would like to congratulate those who have contributed. We are taking people as our center, and we continue our efforts. And I would like to greet all the societies of health and social workers, and we are closely connected to our brothers and sisters through our religion. And I would like to thank you very much for your participation. Welcome again. We would like to thank Devlet Sert for his greeting opening speech. Now I would like to continue with the Specialist Dr. Abdullatif Faslı, Secretary General of World Islamic Health Union. The floor is yours. Please don't forget the success of Morocco. Let's have a round of applause for Morocco in World Cup.
الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه وسلم تسليما. We who World Islamic Health Union, Dünya İslam Sağlık Birliği 7. Kongresine katılan
I would like to welcome you all to the World Muslim Health Society's 7th Congress and Fairs. Republic of Turkey Presidency board members, health and food politics member Ümmü, Gülşen, Öztürk, and Ertuğrul Soysal, the Minister of Labor and Social Security, Deputy Minister Altuntaş, Ankara Müftü, Devlet, Sert, Secretary General Sağlık, and also our online participants from America, Dr. Muhammed, the co-chair of the Congress, and our Congress chair, Professor Dr. Doğan, Ünal, and I would like to welcome you all, and the representatives of the Congress, representatives of those who have contributed for the organization of the Congress. I would like to welcome you all one by one with due respect. As you know, this started in 2016 with 64 countries, with the participation of the 64 countries. World WIHU is established, and with the participation of the other countries, now we have reached a number of 96 members, and now we are one of the international healthcare NGOs, and I would like to thank Dr. Khamis-American, the founding chairs, and I would like to thank our representatives from 96 members. I want to thank them very much for their efforts. In 2023, we will have the 100th anniversary for Turkey, and this will be beneficial for all world Muslims, and we want to have bilateral scientific relations too. And for the future, we would like to have a just, fair, healthy, and peaceful world. And in line with those goals, I wish that the 7th World Muslim Health Societies Congress will be successful. And I would like to thank those who have participated here in the venue, or also who are joining online. Thank you very much for your participation. Thank you very much, distinguished Secretary General, for this great speech. Now I would like to invite Ankara İl Müftü Dr. Hasan Çınar with a round of applause. The floor is yours. Distinguished participants, I'm really glad to be here among this audience, and I would like to thank the Secretary General, Dr. Kasım, for inviting me to this event. The topic is medicine. Maybe you ask what is Mufti is doing here, but don't say something like that, because we have our responsibility. At least we pray, and we have the World Health Union, and I have just learned that we have 96 members, and I'm really proud. Thank Allah. This means the Muslims are also trying to do something here in this field. I would like to congratulate the trade union chair. I will talk about something else, some different aspect. Maybe this is one of I think your topic is cancer. You will be talking about cancer, and this Congress, humanity has not been able to resolve this problem. We are face to face with this, and when there was the recitation of Quran, he used a phrase, and there is a concept. There are two concepts. One is praying prayers like namaz or fasting. We also have ubudiyet in Arabic, and it means that acceptance by the person, which is given for the person by Allah. And our Prophet was saying, if there is a remedy for everything other than death. This is a hadith, and I say that with Allah's support, you will be resolving deathly, fatal diseases. You will find remedies for them, and you have found for some of them already. And there are some diseases which were killing millions of people in the past, but now there is no one dying because of this disease. I believe that this cancer will be resolved in one way or another, and of course with your support as scientists. This might be a Muslim person or not. It doesn't matter. Allah does this, gives this support with the hands of people. So what should we do with, when we come face to face with the sick people? It is said that we test our people with fears and famine, or sometimes by taking those loved ones. And if you are successful, then comes the good news of heaven. And patience is important here. And it is said that, according to what you just said, Yusuf was eaten by wolves. I will just wait for God's support, and I will just be patient. And then, what does it mean, what you said? Because the prophet, our prophet, has three responsibilities. First one is announcement, and the other one is demonstration. And for this reason, the Prophet himself described sabr jamil, patience. It means that there is no complaint in this patience. This is called sabr jamil. When we come face to face with problems, we need to say, God, Allah gave this to me, and this is okay. We need to be able to say this. This is sabr jamil. No, there should be no complaint. Of course, after taking all the necessary precautions. This is the definition by our Prophet. Sabr jamil might be translated into Turkish as good patience, but this is the description of sabr jamil. It should not include any complaint. Distinguished participants, our Prophet had 7 children, and one of them, except for Fatma, 6 of them died when he was alive. I always tell this in the mosque and in conferences and to the participants. And he buried his 6 children. There are people who are suffering only because they buried their just one child. But the Prophet, our Prophet, buried his 6 children, and he cried when he was burying Ibrahim, and he said that it is okay. This is just okay. We can have tears in our eyes, but we should not. We should not be crying, and we should not be crying all the day. And this should not be like that. But you know that as physicians, as doctors, as the World Muslim Health Society, I would like to have a request from you. We are a Muslim society. When we have a Muslim person, of course, after all, the controls, examinations. You have a report, and in this report it says that there is a cancer in this woman or in this part of the body. And people have goosebumps when they hear this. They are depressed suddenly, and when the doctor, if you say directly to the face, it is really hard. This person, when they get out of the room, are not able to walk. Sometimes they're depressed, they're stressed, they don't know what to do, and you know this best. And we know that psychiatrists and the psychologists, psychological world can use this. We cannot treat my Muslim with the views of Freud. The doctor should say that the tests are over. We should not give up on God's hope. We should read this verse. And our Prophet says that if you have a fatal disease and if you are patient, then this will be atonement for your sins. But we will take all the precautions. The decision will be made by Allah, but we need to use all kind of treatments. Sometimes they come to me and I say that they should go to the physician. Sometimes they ask whether they should fast during the Ramadan, and I say that you should ask the doctor. If the doctor says no, you will not fast. And if you fast, even though doctor says no, this is like a suicidal act. So you will listen to God. You will listen to doctors. God can be, the oath can be taken in the name of God only. And when you are face to face with a Muslim, please say that, be patient, and you will see that at the end of the day, you will have your results. And you have given me the microphone. I will continue until the evening. Tell me about it. So I will give you a gift and then go down. What is the gift of the Mufti? It is a verse. Prophet says that 5 people are martyrs. Those who die in the fires, those who are drowned in water, died. My mother was during the delivery, or who died during the earthquake, and who died because fatal disease like COVID or cancer. Those are martyrs. This is said by Prophet. So this is a gift from me. May God help all of you. Hopefully you will be successful. Thank you.
Çok kıymetli
We would like to thank the Mufti, now the member of Presidency, Health Policies Council, Ümmü Gülşen is not here with us. We wish that she recovers soon. And also our Deputy Minister Ertuğrul Soysal, he has to attend the budget meeting, and I would like to send their regards from Ümmü Gülşen, Öztürk, and Mr. Ertuğrul Soysal. Our event began at 8:30 this morning, and we are sharing this event in English in 42 languages. We have colleagues here who have done great work, and we broadcasted that event online, and I would like to invite these successful colleagues to the stage for award ceremony. Could you give me those awards? Thank you. I would like to present the best 5 ideas. The first one is, and I would like to invite Dr. Khamis-American to the stage to present the awards. Ajna Hukic Sound Nomad from Bosnia-Herzegovina. The second prize, Syed Rafael, My Voyage Plan. Third prize, McKinsey Porsche brand is here. If the entrepreneur is here, please come to the stage. Samjak Solahi Joybari Asi, third place. And the last one, Basim Safadi, Smart HR. These are the 5 best ideas. I would like to thank them all. Mr. President, they have all participated online, and they are coming from different parts of the world, and I will accept their awards on behalf of these successful people. A microphone, please, for the president. Thank you. Our President Khamis-American is working really hard for this. Thank you. Since the World Health Society's Congress and fairs began, we have been doing these contests in the field of healthcare. This year, maybe less than 50% of these people are working in the healthcare industry, and they are from all kinds of technological fields. Next year, we are going to be in Algeria, and we have a guest from Algeria. Let's hear for him. And organizer of our next Congress is from Algeria, and hopefully we will also broadcast our event in Algeria online. And the young people are so interested in this contest, and hopefully it will continue. And currently we have participants from 28 countries. This technological contest has been attended by many people from 28 countries, and on behalf of the participants, prize winners, I would like to present their awards to Mr. Yavuz. I wish you all success in life. We are lucky to have you. Now, on the startup section, I will present the first 5 prize winners, and we will interview the participants who are in the top 10 categories. Turan Can Ekmekçi, Devium. Congratulations. Do we have anyone from Devian? Please come over to the stage. Let's hear for them. Devian, the best startup prize. Congratulations. Turan Bey, congratulations. This is a huge success. And among all different kinds of projects, you have been chosen for this award. In the first section, we did not have our colleagues. Could you explain to us in 30 seconds what Devian does? Now 25. This is a software developing platform on blockchain, and the source code, NFT, licensed source codes are available on this platform, and we market them online. This is the summary. This is a nice summary. And to present this award, the head of Technopark Istanbul, Orhan Çömlek, please come over to the stage. Welcome, Welcome to our event. Please present the award to the startup champion. I hope I don't have 30 seconds. You have 1 minute. Please present the award. I know this company. They had received previous awards and they also received investment. They are not working with smaller investments. If they did, we would support them with a small investment, but it was not possible. I would like to thank all participants. This is a great event, and there are so many successful companies. Devium is one of them. I wish you success, and I would like to present your award, the Best Startup Prize. Congratulations. Thank you, Orhan Bey. The best second startup, Gökhan Sağlam, Validos Biomedical. Third best startup prize, Salah Gallo, joining us online. The fourth best startup, Hilal Fidan, Octagram Technologies. Please come over to the stage. Let's hear for them. Octagram Technology. And to present the award, Kürşat Dalkıç. I would like to invite him to the stage. Can we have another microphone for the Octagram? You have 30 seconds to summarize what you're doing, and Kürşat Bey will present your awards. Please explain to us what Octagram Technologies do. We provide consultancy services for the medical equipment producers, and we want to make sure that they work in line with the health legislation, and we want to facilitate the medical services, facilitation of medical services, and we develop technologies for that. I'm really happy to be here. Thank you, Yavuz. As an entrepreneur, as someone who entered the field at a young age, I would like to thank you for providing them this platform. I would like to present your award, and I wish you success in your commercial life. Let's have a picture together. Congratulations, Octagram Technologies. Thank you again. Thank you. We are glad you are here. And lastly, Ahmet Cevahir Çınar. He's joining us online. Organic Advertising Network. Let's hear it for this country is the apple of Turkey, Çorap. And to present the award of Çorap, we will invite a humble but very successful person, Gözde Tüysüz. You have 30 seconds. I know you can do it in 10 seconds. Çorap means online advertising program, and we bring together people who have who provide tasks on social media. We have 30,000 members, and we are growing. This is a special award. Thank you, Yavuz. Thank you for inviting us to this event, and I wish you success. Thank you. I would like to add one more thing. I think there's another event in Ankara Tekmer, and maybe we will see each other at another event. Now we are working for possible investment. And we would like to see Gözde in Ankara Technology Center. Let's have a family photo. Please come over to the stage. Everyone, please come over to the stage. Let's remove this chair. We want to include everyone to this family photo.
Aynen, bir sandalye ve masayı alalım ricam. Girişimcileri arkaya alalım.
Let's have the entrepreneurs to behind us. You are our future.
Tamam. Tamam başkanım. Şimdi herkes
Let's gather everyone here for the photo, then we will have a 10-minute break. We want to have everyone on the stage. This will be a happy family photo.
NTR TV ekibi Eren'e bakalım. NTR
TV is broadcasting this to 9 billion people. Look at the cameraman, please. He's raising his hand. Mr. President, let's stay still. 1, 2, 3. Say cheese. Big smile.
an Teknoloji Bakanımızın
I will begin with a message from our Industry and Technology Minister, Mr. Mustafa Varank.
alalım. 06 BGR 779. Teşekkür ediyorum. Euzubillahimineşşeytanirracim. Bismillahirrahmanirrahim. In the name of Allah, the most gracious, the most merciful. Öncelikle Sayın
First of all, I would like to read a message from our Industry and Technology Minister, Mr. Mustafa Varank. Distinguished Muslim Health Society and Sağlık, thank you for your kind invitation. Unfortunately, I won't be able to attend the event due to my busy schedule. I would like to thank you and all distinguished participants attending the 7th World Muslim Health Societies Congress. Minister of Industry and Technology, Mustafa Varank. And I would like to invite Mustafa Varank to start our first session. After a break of 2 years due to the pandemic, we haven't been able to come together, but we have the perseverance. We are here to celebrate the 7th World Muslim Health Societies Congress. Me and Mr. Muhammed, we will be moderating this session. For the first speech, we would like to invite Dr. Murat Türk Yılmaz. Mr. Head of Congress, distinguished professors, and all the participants who are visiting us from different parts of the world, I would like to salute you all with my deepest regards. Thank you for inviting us to this session. I would like to explain to you briefly the cancer epidemiology in Turkey and in the world. As it was mentioned in the opening speeches, cancer is an important health problem in Turkey and in the world. As the global population ages, it is foreseen that 29 million new cancer cases will be seen in 2040. And when we look at the new cases, the difference between the sexes is not too big, but cumulatively, males have more cancer cases. Lung cancer is the first one in males, and breast cancer is the highest one in females. And in the world, the first one for women is the breast cancer, the second one is colorectal, and the third one is lung cancer. And the risk of developing cancer by the age of 75 is 20% in the world. The incidence of cancer in both men and women are higher in Europe, Canada, US, and Australia, and it is estimated that 1 of every 6 deaths is because of the cancer. When we look at the income levels, low income levels have a higher incidence mortality, and in higher income level populations, the incidence and mortality are lower. When we look at the World Cancer Report, the cancer incidence will be increasing with the increase of population, and this increase will be affecting the low-income countries more. In males, cancer incidence, the prostate cancer incidence is higher in Europe, North America, South America, but in Turkey and Asia, lung cancer is the first one, has the most incidence. In women, the breast cancer is the most common in the world. In Africa, cervical cancer incidence is higher. When we look at the overall situation, the breast cancer is higher, lung cancer is 15%, colorectal and prostate cancer follow them. When we look at the distribution of cancer cases in male and female, lung and prostate cancers are followed by colorectal, stomach cancer, and liver cancer in males. When we look at women, the most common one is the breast cancer, followed by colorectal and lung cancer. As we all know, the risk factors are usually the environmental factors, and from 5 to 10% genetic factors are effective. Tobacco use affects cancer from 30 to 35%. Nutrition affects the cancer incidence from 25 to 30%, and alcohol also is a risk factor. The deaths from cancer are affected by the use of tobacco, high BMI, use of alcohol, and the 1/3 of cancer deaths are caused by these. And in the world, 13% of carcinogenic infections are the cause of cancer, such as Helicobacter infections. When we look at the cancer epidemiology in Turkey, let's look at the cause of death in Turkey. The first reason of death in Turkey is the heart disease and ischemic heart disease. The second one is cancer. When we look at the standard cancer speed based on age, the men are higher than women based on the 2018 statistics. When we look at the cancer cases in Turkey, in males, trachea, bronchial, and lung cancers are followed by prostates. In women, breast cancer is the first one, and it's followed by thyroid, colorectal cancers. This is the distribution in Turkey. As I mentioned, 21% of cancers, male cancers in Turkey, are tracheal, bronchi, and lung cancers. And in women, 26% are breast cancers, and they are followed by thyroids. In Turkey, more than 24,000 women are diagnosed with cancer, and 1 in 4 are breast cancers. And in the 0 to 14 years of age, they are usually different from the adult cancer types. Half of them are leukemia. When we look at the survival rates between 2015 and 2019, when we look at the 5-year survival rates, it increased from 80% to 82% in 2015. Rectal cancer is in rectal cancer, survival rate increased from 49% to 52%. And the colon cancer increased from 52% to 52.4%. And as in other countries, Turkey also implements a national cancer control program. And we all know that cancer is going to be a problem that creates a financial burden in all countries. So we were asked to create a cancer control program. And in 2018, we initiated this program. And based on the changing algorithms, we update the program. And this program is composed of different components. The first one is registration. Dr. Ege will mention more. And the next one is prevention. Next one is screening, and it will be mentioned in another presentation today. And there is the therapy components. As I mentioned before, between 2008 and 2013, the first phase booklet was published. Between 2013-2018, phase 2 booklet was published. And you can download the booklet from the webpage of Ministry. Thank you for your attention.
Sağ olun hocam.
Thank you very much. Our cancer department chair, Murat Türkülmez, thank you very much. He told us cancer in the world, and we don't have a high spirit right now because of all this data. But how can we early detect, have an early diagnosis of these cancers, and what kind of treatment methods can be used? As mentioned previously, we need to protect ourselves. Prevention is important. Cancer screening, treatment, and diagnosis are all important. And cancer department in Turkey has been exerting great efforts. So we are proud of this department. They have very significant activities in terms of prevention. And the second speaker is Dr. Fahriye Ünlü from Public Health General Directorate, Department of Cancer. She will talk about early diagnosis and scanning methods in the world and Turkey. Hello everyone, distinguished participants, my distinguished moderators, chairs, my dear colleagues, and dear guests. We will share current and up-to-date developments and experiences. And now we are here in the Cancer in the World session. I will talk about the early diagnosis and scanning. I'm really excited and honored to be here with you. And I would like to thank the Congress organization. And I believe that this is a very effective and beneficial activity. Now I will start with my presentation. What is early diagnosis? It is the diagnosis when the symptoms are not preventing this person from working or other issues, and the delay of the diagnosis may eliminate the possibility of the treatment. So it is really important. What is the importance of early diagnosis? It increases significantly the success rate of treatment, and it facilitates the treatments, decrease the time duration for treatment, and decrease the cost of treatment, and it increases the life span. It is screening is an early diagnosis method. We are not just we are looking at asymptomatic people, and we try to we are checking whether there's a positive findings, and these positive findings, if any, are sent to the more advanced methods, and the main objective is to increase the life span. And there are there are two types of screenings, society community-based screening. The community as a whole is invited for early diagnosis and treatment. They are examined, and we also have the opportunist screening. And if there are some risky situations, we can use this kind of screening. And what is the rationale of the screening? World Health Organization defined this in 1968, and the European Council of Europe had some principles for screening published in 1994, and Turkey is a member of Council of Europe. What are the screening principles? The disease should be an important health issue for the community to be scanned, to be screened. And when we have an early diagnosis, we should also have a treatment for this. And the benefits should be higher than the unexpected, unwanted side effects, and the screening should be continuous. How a good screening test is defined. It should be accepted by the people who are going to be screened. It should be practical. It should be reliable. It should be non-invasive or pre-invasive. And you can see the symptoms and you can see the stages of the disease. And the screening may happen before the symptoms emerge. And this is the service given to the target population, and then we have the symptoms, then we have the early diagnosis, and we can have an early diagnosis for them too. And the world, we have cancer treatments for cervix cancer, breast cancer, colorectal cancers. In some countries, ovarian cancer, abdominal cancer, skin cancer, lung cancer is also screened, but it is not national on a national base. I talked about the two types of screening already. In United States, this cancer screening is not paid, not for free, and there is Medicaid program, and in this program, cancer screening is not paid, is free, and mammography can be done for every year for the people who are between the age of 40 and 74. For uterine and cervix, the pap smear test can be done every 2 years. And in European Union, since 2003, they have community-based breast, cervical, and colorectal cancer screenings. And since that time, all EU countries, EU member states, have been implementing different screening programs. They screen breast with mammograph, and for 45, 48, 49 years, every 2-3 years. For uterine and cervix, it changes in different countries, but they check it every 3 to 5 years. For colorectal, they have a check every 2 years. In Canada, it is for free. Mammography is for every 2 or 3 years. And pap smear is done every 3 years. And for colorectal, test is done for every 2 years. If you can see Australia, and pap smear is done every 2 years. And for pap smear, for colorectal, it is every 2 years. In New Zealand, they screen breast, cervix, and antenatal HIV. And UK uses mammography, and cervix is also screened. And for colorectal, they have 2 screenings for every 2 years. In Spain, there are 17 different regions and the regional healthcare systems. Breast cancer screening is the oldest program, and in 2015 they started a program for colorectal cancer screening. Cervix cancer screening program is now being implemented, and an invitation is sent to women for the women who have not tested for the last 3 years. In Egypt, there is just mammography, the national level screening program. In China, there is no routine cancer screening program. In India, there is breast and cervix cancer screening. They did this in 2016 for the first time. So you can see the World Health Organization 2022 data as mentioned here. As you can see here, in Turkey, community-based screening program is implemented. In Syria, in Iraq, Saudi Arabia, Pakistan, Oman, we don't have screenings. In United Arab Emirates, Turkmenistan, Myanmar, Bangladesh, we don't know. And in Kenya, there are opportunistic screenings, but we don't know anything about the details and the data. You can see the different colors show the different types of screenings. We also have community-based healthcare centers. So we have cancer centers, family healthcare centers, and we also have mobile cancer screening devices, screening vehicles, and all these screenings are for free. In 2004, we had 4 cancer early detection, screening, and training centers. And they're called KITAM, and now their number has increased significantly, and 14 of them are mobile. You can see the screening standards of national cancer screening standards. This is for the breast cancer, and cervix cancer, and colon cancers. For mammography is recommended every 2 years for the women between the ages of 40 and 69. HPV, DNA, and pap smear test is used every 5 years between women between the ages of 30 and 65. For colon cancer, we recommend colonoscopy every 10 years. And you can see the national screening standards. They were published in 2007, and there have been some changes when necessary. It is updated. Breast cancer screening. You can see that we have you can see the existence of national screening program for breast cancer in the world. And in the world, many countries are conducting screenings for breast cancers. And you can see the European guidelines for quality assurance in breast cancer screening and diagnosis. This is the 4th edition. Quality criteria are sine qua non for the screenings. And you can see the breast cancer incidence in our country. This is 2017 data. It is 47.7. Mammography is used. The world is using this, and you can see the process of you can see the system of national mammograph. We have the 204 centers, 43 mobile vehicles, and they are integrated to central reporting, and all mammography information are sent to screening health gov.tr website. This project started in 2016. You can see the mammography evaluation process. We have radiologists who are trained to read the mammography, and there is double-blind readings. We have the first reader does not see the result of the second reader, or the second reader does not know the result. If we have the same result, then we have the result. It is reported. We are using BI-RADS scoring, and then we have a third radiologist who is more experienced, and the result is reported. You can see the reporting centers. For mammography, we can give the results in 10 days, and recall rate is about 70%. between 7 to 10%. You can see the mammography screening process algorithm. If BIRATs want to, we invite them for after 2 years. If it is BIRATs for 5, we need required advanced techniques and advanced examinations tests. You can see the screenings in Turkey. It was up to 5 million. Screenings, and in our department we conducted a study about the results of the 2016 screenings, and this is in line with the literature. BIRATs 5 are diagnosed with cancer in 93% of the cases. And for BIRATs 0, we have cancer diagnosis for 9% of those patients. You can see the existence of national screening program for cervical cancer, and in all around the world, many countries are conducting cervical cancer screening. And now we can see the screening methods. Generally, they are using histology for cervical cancer. Very little countries use HPV and DNA. Very few countries, and incidences shown here. But the information about the cervical cancer, almost all of them are caused by human papillomavirus. It has some certain oncogenic types, and if they are not treated, sometimes in years they might turn into invasive cancer, and it is accepted as a preventable disease by the World Health Organization. When it is diagnosed early, we have a chance of treatment for 100%, and even if we have one check in the world in our lives, then the death risk for cervical cancer is decreased by 50%. We have national HPV laboratory, and all the samples in Turkey are sent to these two laboratories and are evaluated in those laboratories. And you can see we were using histology, and in 2014 we started using HPV DNA, and we had the positivity map in Turkey, and our country is among the countries which is using this HPV screening. The third cancer is colorectal cancer for the men and women between the ages of 50 and 70. Occult blood in Gaeta is checked, and every 10 years the colonoscopy is also recommended. The incidence is here, and occult blood test is used every 2 years, and you can see the algorithm. If we have the positive results, then we send them to the hospitals. They're already designated, and in the results report you can see the names of the diagnostics centers. And what is the aim objective of these centers? We want to detect these cases as early as possible, and we want them to receive support of the professionals. So you can see the screening rate in Turkey. We had a great momentum before pandemic, especially in terms of cervical cancer. But when we look at the 2022, breast cancer it is 26 for cervical, it is 50, and colorectal it is 15. So we are about to reach the momentum before the pandemic, and you can see the stage distributions according to the screening cancers. In 2016, long stage was 12, and then it is decreased. Localized was 46, and in 2017 it was 47. And we can see that the screening was successful. And let's look at the cervical cancer. It was 49.5 localized stage, and in 2017 it was 55.2, and participation to the screening was higher in cervical cancer, and for distant metastasis was about 15%. In 2017 it is 10.4. So for colorectal, the participation to screening is not too high, so there was not a significant increase. We have a cancer appointment system, and you can see the interface main page of this system. They are trying to follow their target audience, target population. You can see the algorithm. Which screening is suitable for me is on our website. Our citizens can go online, enter their information, and they can understand which screening is suitable for them and where they can be done. You can see the hand brochures we use for the trainings, and you can see a video we prepared for the training. So as a result, what is really important is that the symptoms should be taught to people. Symptoms of the cancer should be taught. We need to increase the people's health literacy, and in this way we can prevent cancer and we can treat it. We should be aware, and we should be with our loved ones. Thank you very much. Thank you. You summarized it all in short. You summarized the importance of screening, and now we will continue with the next speaker. And from Public Health General Directorate, Dr. Ege Hamavioğlu, Turkey Cancer Recording System. Thank you very much. Distinguished participants, distinguished chairman, my dear colleagues, I will talk about the registry, the cancer registry system. Firstly, I would like to start with Dr. Christopher P. Wilde, the old director of the International Cancer Research Institute. Cancer is costly. Before everything, we have the cost of human who is suffering from cancer, because we know that cancer is affecting people, individuals, both physically and emotionally, and we know that the mortality is high, and this is the second most frequent. This is ranking the second mortality reason in the world. And in 2020, 10 million deaths that's happened because of cancer. Its morbidity is also high, as its mortality, and within this framework, national and international action plans are prepared, and one of them is the United Nations Sustainable Development Goals, and until 2030, there is an item, there's an objective about early deaths caused by cancer and chronic diseases. This is also an objective of the goals. And I want to talk about cancer surveillance. With cancer surveillance, we can have some information, we can collect some information about the national and international status, we can understand our needs more clearly. And we all know that about each cancer type, we need to have detailed data, and we need to understand. We can use this data to understand this complex disease. We should have the knowledge, and we should turn this into information, and then we have the data. They are collected. We analyze them, and we have the information, and then we make a decision about this, and then it turns into knowledge. Which health policies should be developed, can be planned, and for cancers, the priorities are evaluated, understood, and we focus on the cancer types which are more frequent in that specific region, and we now focus on the cancer registry. Cancer registry is where all the information about all malign and benign neoplasm cases, and they also include the clinical and pathological indicators of them. And it has an international rule. It has international rules, and it is a dynamic process. So we can also call this cancer surveillance. Cancer surveillance is the main tool in cancer epidemiology. Why is that? Because with cancer surveillance, we can calculate incidence, we can focus on prevalence or survival, and we can detect mortality, we can think about the risks, and we can calculate some other epidemiological measures. And when we are able to have this data, we can make plans and programs, and this is the starting point for the fight against cancer. And let's look at the details of the cancer registries with the data collection methods and comprehensive data is important. We can have passive or active methods, or hospital-based or population-based. In passive data collection, the data is shared by the institution or people who diagnose the cancer. Passive cancer registry activities are still ongoing, but there are some missing parts. Some parts are not included. So in time, this system is stopped to be used. Ceased to be used, and then we started active cancer registry system. And this data is collected by those people who are trained in the field of cancer registration, and there are international standards for that, so we need those people to be trained in cancer registry. And we also have hospital-based cancer registry. We are talking about those people who come to a certain healthcare institute, and the main objective in hospital base is to evaluate the hospital itself. And this is the population-based registration. They collect the information, cancer case information, in the population, a certain population. Most important system is the community-based, population-based, and active registries. And with these systems, we can have reliable, valid cancer data. So this is also recommended by the World Health Organization. And let's define the population-based active cancer registry. It is collecting the data about all each cancer cases in a population, in a finely defined population. We collect malign cancers or primary cancers, in situ cancers, and we also collect benign and borderline tumors, which are in the central nervous system and medulla spinalis, and we can find the cancer incidence with the support of this system, and this is a golden standard for us. We generally work on prevalence, and when we are preparing the policies or action plans, we can look at the incidence and prevalence. But for cancer, when we are making those decisions and when we are deciding upon this international national policies, we generally use incidence measures. And what are the achievements, benefits of this population-based cancer registry? It helps us to understand the cancer load and its geographical distributions. We can understand the reasons of cancer, and we can conduct analysis, survival analysis, population-based survival analysis. We can define the policies to be implemented. and we can evaluate the effectiveness, impact of the interventions or responses, and we can make sure that the necessary improvement studies are done just in time, and we can provide significant contribution for the control of cancer through the methods like the diagnosis of cancer, treatment, and evaluation of care quality. In Turkey, I wanted to give some details about the cancer registration activities in Turkey. We started to collect this data with the establishment of the head of the Department of Cancer, fight against cancer. It was passive collection, as I mentioned, but then we turned to active cancer, active data collection, and for the first time in 1992, we started the active cancer registration in Izmir Cancer Registry Center, and then the number increased with Antalya Center, and after 2000 we started to have new centers in Bursa, Eskişehir, Samsun, etc., and we increased the number of these centers, and in 2013 we started to have the cancer, we had cancer registry centers in all our 81 provinces in Turkey. How the system is functioning? First, we need to have the cancer registry personnel, which are trained. Our data resources are hospitals, public hospitals, private hospitals, pathology centers, oncological treatment centers. So those centers where the cancer patients go are all resources for us, data resources for us. And in hospitals, there are units for cancer registration, and the personnel working there enter the data, and they also receive a registration training, and they transfer all this information data into a form, and these forms are sent to provincial health directorates. They are sent to these cancer registry centers, and the first stage, like the duplications are evaluated, multiple primaries are evaluated, and then sent to CanREC system. These forms, of course, this goes step by step, and it comes to the cancer department. And in cancer department, they look at coherencies, major and minor coherencies, quality criteria are also checked again, and then we have the final analysis, and it is turned into reports. It looks like really simple when we are reading like that, but starting from the first step, it is a long and hard process. And in many countries, cancer statistic reports are showing the previous year's data. We had the COVID pandemic, and this affected, and this caused some delays in all countries' cancer statistical reports. And our country's 2018 report is about to be published. The United States has just published its 2019 report. Germany shared 2017 and 18 reports in September, and we can understand why it is not up to date. This is why I would like to share this. It requires a very long time. The analysis of the cancer data is taking really long time, so it causes a delay of at least 2 years. So what can we have with this cancer data? When we collect all this data, we have an analysis process, and after that we see the status of the country and the cities and the regions, provinces, and the most important epidemiological information is incidence, as I said before. And as you can see, we can calculate the cancer incidence based by years, and we can also designate the most frequent cancers. It is important because we need to plan our actions by looking at the most frequent cancers. Are we going to have prevention studies? We need to program all these things. and we detect these most frequent cancers, and we can have the action plans. And we can have some other specific studies. We can have some age-specific rates. For example, there are some age-specific rates for male cancers, and this is a basis for all the other studies. And with the support of this data, we can have other different scientific studies.
This is another example of a common cancer type in women. And we look at the age distribution here based on different types of cancer. We publish our reports regularly on the website of Healthcare Directorate of the Ministry. And here we have participants, doctors who work in the academic field, and you can find the data on this website in these reports. And I would like to mention the population effect, and the number of cancer registry centers is increasing, and we include the data collected from the cancer register centers in our report. In our first report in 2008, we had 9 cancer registry centers, but in 2017 we had 14 cancer registry centers with quality data, so we included them in our cancer reports. And you can see the provinces that are included in the report data. We wanted to have different provinces that would reflect representative data. As I mentioned earlier in my speech, cancer registry is a system with global rules and standards, so it requires training to understand that. And cancer registry is done by trained personnel. So our department organizes 3-day-long trainings. The first training, basic cancer registry training, is for 4 days, and staging training is also for 3 days, and cancer register training takes 3 days, so they can become involved in cancer register processes under our department. And we maintain cancer register systems in line with the global rules and standards. The reason is, if we follow these standards, we can compare the countries, we can compare the regions. I can compare Turkey to Germany, Oman, Uzbekistan, if I follow the same standards. So in our country, we do the cancer registry with the monitoring of international guidance. And there are guidebooks published by WHO and others. Of course, we also share our national data with the WHO, and we also have them included in the international publications. In the 9th volume of this book by the WHO, we shared our local cancer registry data, and data from 8 of our local cancer registry centers were published in an international journal. And of course, in the 12th volume, they are going to include our recently shared data. We are also involved in Concord. This is a surveillance work, and this year they are going to have an event, and we will share data with them. And this at this event, they present survival data and indicators, and we have shared some data with them, and we have received acceptance. There are 6 IARC regional hubs in the world. These cancer registration hubs are in LMIC, and with a protocol, we received approval for a cancer registration center in Izmir, and you can see that there are hubs in Northern Africa, Central and Western Asia, and we also give support to these regions that you see on the map. Cancer registration is a part of international cancer control programs, and this is a very important component of cancer control programs, and WHO recommends that it should be done in every country, and we hope to make progress in our country in the future. Thank you. Thank you, Ege Hanım. This was very comprehensive. This was very interesting. And the next speech is Dr. Wahib Harun, Cancer in Africa. We always talk about the variations, national and global variations in cancer, and we want to see the differences in regions. So let's hear what Dr. Wahib is going to say about this.
Şunu tat işlemi yapıyoruz yoksa?
Alabiliyor musunuz arkadaşlar? Değiştirebiliyor muyum?
Thanks. Bismillahirrahmanirrahim. Herkese selamlar ve saygılar.
With my deepest regards to everyone, I would like to talk about cancer in Africa. I would like to extend my regards to everyone. I would like to talk about the cancer cases in Africa. You may know that cancer is the most imminent health care problem in Africa today. In addition to HIV and tuberculosis, cancer is killing more people in Africa than these diseases. In the next 5 years, the number of people dying from cancer may surpass 1 million. and the world countries should come together to come over the cancer crisis in Africa. When we look at the history of cancer in Africa, in 2600 BC, there was a doctor, Imhotep, who lived in Egypt, and he is the first doctor to identify a tumor, and it was his recommendation to cut out the tumor and stop the infection, and his theory was that the body would heal itself. And it is called spontaneous regression. Think about it. We have recent developments in cancer, and this method was developed around 2000 BC. The self-healing characteristics of the body was discovered. Now we call it immune therapy. Spontaneous regression was discovered around 2000 BC. And when you look at the recent cancer development, you can see how the cell moves. The immune cells in the body, how they destroy the cancer cells. The incidence of cancer in Africa is seen here. I will give you an example. For instance, let's look at the incidence, cancer incidence in Sudan. The most common cancer types are breast cancers and cervical cancers. In males, lung and prostate cancers are the most prevalent, and leukemia in children. Leukemia is the most common in children. Let's look at Egypt. Again, in women, the breast cancer is the most common. In children, leukemia and lymphoma are the most common types of cancer. Let's look at the cancer incidence in females in Kenya. The most common ones in Africa are the breast cancer and cervical cancer. Let's look at the Morocco example. Again, in females, breast and cervical cancer are very high. In males, colon and lung cancer are really high. In Nigerian example, breast and cervical cancer are the highest. In males, prostate and liver cancer are the highest ones. Let's look at the incidence of cancer in South Africa. It's the same. Again, prostate and lung cancer are the most common in males. Breast cancer and cervical cancer are the most common in females. So these four types of cancer, prostate, lung, breast, and cervical cancer, they are the same in every African country. They are really common. In Gabon, the incidence of breast cancer are really high, and the deaths from breast cancer constitutes 0.70% of all deaths in Gabon, according to WHO. Let's look at the Ghana example. The most common are the breast and cervical cancer, and the most common in males is the prostate cancer. According to the WHO, according to the International Agency Research on Cancer, there will be 1.4 million cancer patients in Africa by 2030. As I mentioned earlier, the most common type of cancer in women in Africa is the breast cancer. And there's also the cervical cancer. These are either hereditary or age. In African males, the most common types of cancer are prostate or lung cancer. In African children, it's usually leukemia. And there's also non-Hodgkin lymphoma types. These are very common. Since the breast cancer is so common in African countries, it is considered as the most dangerous type of cancer. As my colleagues mentioned, there are specific types of breast cancer diagnosis, self-examination, biopsy, mammography, Doppler ultrasound, ultrasonography of the breast, and surgical biopsy is also an option. You can see the different types of diagnosis, but these are not available in every part of Africa, and they are also very costly. There are some developments in the world, such as endomicroscopic screening device, and they are helpful in early diagnosis of cancer cells, and they also help us remove the cancerous cells and remain the healthy tissue intact. As I mentioned, the cervical cancer is very common, and this is also common in high-income countries. The prevalence is more than 85%. In Africa, the prevalence of cervical cancer is not above 15%. It is caused by human papilloma virus. It's a sexually transmitted virus, and it causes the cervical cancer development. More than 90% of the women who are diagnosed with cervical cancer have the HPV virus, so it causes the cervical cancer. So let's remember that. Protection from cervical cancer can be done by protecting people from human papilloma virus, and it can be also done by vaccination. Vaccination should be repeated every 5 years. Let's look at the colon cancer. This is one of the most common malign diseases. In addition to hereditary factors, high consumption of alcohol is also a cause of the colon cancer, so the patient should stay away from the alcohol. Pancreatic cancer is also a very dangerous type of cancer, as the lung cancer is caused by this damn cigarettes. Tobacco is the first reason causing this type of cancer. Since this is one of the most common types of cancer, it's a dangerous type of cancer. The state, the media, everyone should be educated about this. They must be educated about the risks of cigarettes, which makes you purchase your death by your own money. Mouth cancer. We have a different type of tobacco called tumbak, and it's used by chewing, and it's very dangerous. It's really ugly. You can see in the picture. The mouth, oral cancer, it affects the different types of mouth, such as the tongue and gum. So they take this different type of tobacco and they mix it with soil and then they chew it. This is an ugly type of cancer. But in the beginning, it progresses very smoothly and it is difficult to identify in early stages. And I will mention the cancer issues in Africa. As you may know, the medication is costly. There's not enough. There are not enough doctors. We don't have educated doctors. And the pathologists are not available at. There's only one educated pathologist for every million people. The diagnosis is usually done very late because then women and the patient, especially women, they seek diagnosis in a later stage. They feel something in the cervical area. They are ashamed by that. They don't go to a doctor. And if there's a diagnosis, she will be isolated from her society. So training is very important. Therefore, cancer response in Africa requires equipment, experts, and consultation. This is very important. So, how do we respond to the cancer crisis in Africa? As I mentioned, diagnosis is difficult, the medication has a high cost, and there's a lack of experts. So what can we do? We have to do something. First, we need financial resources. We must have centers for the diagnosis and therapy for cancer. People should have healthcare insurance. They must stay away from things that cause cancer, and they must be educated about cancer. In Africa, what should the population do to stay away from cancer? They must stay away from things that cause cancer: cigarettes, tobacco, alcohol, prostitution, and HPV. HPV is the reason that causes cancer. As you know, that cigarettes cause esophageal cancer, stomach cancer. You can see that there's a woman here smoking cigarettes. She's just killing herself. She's posing, but killing herself. Cancer response in Africa is should be handled by the medical society in Africa. There were people in this world, they got sick, there was no technology. How did they respond to diseases? I think in addition to radiation therapy and chemotherapy, we must use conventional plants, natural plants, which support the immune system. These are some plants that are used in treatments, vinca rosea, saxibrofolia. These are used in treatment of leukemia, testicle cancer, breast cancer, and lung cancer, and they are scientifically approved. For instance, Algida inhibits the proliferation of MCF7 cells. And this was proved. These are medications available in the nature. And they are also sold commercially. There are books about them. There are data proving their effectiveness. Let's look at the examples of cancer response by the global healthcare community. What kind of support do they give? This is an example from Sudan. This is a professor from Morocco. They are working against breast cancer. And over the years, he gave many speeches in the parliament. And there's also cooperation between Africa and Turkey. This is an example from Sudan, 2017. This is the Breast Cancer Education Center. It was established by the opening was made by Ms. Emine Erdoğan. In the western part of Sudan, a research hospital was opened, and this hospital serves to 5 different countries. Again, in Turkey, Sudanese children with leukemia are treated. We have a country protocol. Many children have come here for treatment. These African girls are saying thank you before they leave Turkey. In Sudan, there's also radiation therapy center. This is the new hospital in Sudan. This is a private hospital established by investment. There is a breast cancer care center in Khartoum. This is a cancer center to be established in Ethiopia. So finally, the number of new cancer cases in Africa is 307,507, and the number of deaths is 191,000. The most common types of cancer in Africa are breast cancer, lung cancer, liver cancer. So, briefly, when we look at the male and female, the breast cancer, 35%, liver cancer, 13% prevalence. In order to prevent cancer in Africa, we need local and global efforts. Thank you for your attention.
Doktor Vahip için çok teşekkür ederim bu güzel ve kapsamlı hem resimli fotoğraflı sunumun için. soru ve cevap
Thank you, Dr. Wahim, for your interesting presentation with pictures and everything. We are a bit late, so we can have your questions now. One question for each presentation, please. No question. So I have a question for Fahriye and Ege Hanım. I will ask Fahriye Hanım, what are you doing about breast cancer as the ministry? For instance, should we do screenings? For the prostate cancer, we had a workshop in 2015, and it was not recommended. The social screening was not recommended at that workshop. That was our decision. But every citizen who has complaints, of course, they can go to their primary care physicians. And there's no specific test for PSA type, and rectal touche is necessary for the diagnosis. Those who have complaints, symptoms, or those who are above a specific age can go to urologists at hospitals. They have access to that. Thank you. I have a question for Ege Hanım. When I was writing my article, International and National Geographic variation are discussed in my article. When you look at the other countries, European or Middle Eastern countries, does Turkey have any specific characteristics? We can talk about these characteristics based on different types of cancer. When we look at the female cancer cases, the incidents are similar to European examples. When we look at the Globacan data, prostate is more common in other countries, but in Turkey, lung cancer is more common. The best advantage of having global standards in cancer registration is that we can compare. Of course, if we look at the data for different cancer types, we can see the differences. We will close our session here. With Muhammed Bey, we have a recommendation. Before our next event, let's form an oncology working group. And for the Islam nation and the world, World Muslim Health Society, we should have our own database. So thank you. We will have a coffee break now. We will see you in the next session. We have a break for 15 minutes now.
Sayın Başkan, değerli konuklar.
Distinguished participants, this is the second session in the afternoon. My name is Ertuğrul, and I am together with Suhaini Kadiman from Malaysia, and we will talk about the social problems of oncology patients and solutions. And in this session, we will have three presentations. Two of them will be here with us, and one of them will be online. And there was a change in the names, and Mustafa Öztürk will be the first speaker, and then we can ask questions, and then Arzu will talk. She will talk about psychosocial problems and remuneration. Now I would like to invite cancer diagnosis and treatment processes and insurance remunerations. Hello everyone, distinguished participants. We don't have any separation in different systems for oncology, for other systems. In our country, we have the medulla system, and I will inform you about this. And medulla systems benefits will be also my topics in this discussion. The general healthcare insurance was universal healthcare insurance was a dream of our country for many years. They worked on it in 1960s, but with 1982, in our constitution, we have a clear provision article about the universal healthcare insurance. And after AK Party government's ruling in 2002, we made a change, and we issued the law numbered 5510, and now and it started to be implemented for the first time. And within the framework of this law, if all citizens fulfill their own responsibilities, each one of our citizens will be in our system. You can see the scope of the general universal healthcare insurance. Some of them are within the scope as retired, some of them are within the system as active insured, and some of them are not working and older than the age of 18, and they pay 150 Turkish lira to be a part of this system. And this is you can get under the scope as a person, and if you are a family chief, then the whole family, then when you pay this 150, the whole family will be taken under this scope. And the premium, there are people who are not able to pay this premium, even this 150 TL. There are some individuals who are not able to pay that, and the government, and the state is paying their part, and they are still under coverage. And if they are under the age of 18, these children are within the framework of this insurance system, even though their mother or father are not insured. These are not covered, those not covered in the insurance system, the deputy president and the ministers, members of the parliament, and there are members of Constitutional Court, Supreme Court, and generals are also excluded from the system, and their number is about 1.5 million. They have their own institutions, and they have their own coverages in their own institutions. They pay their premiums. They have a different insurance system. So the 83 million is clearly within the scope of, under the coverage of this insurance. Universal insurance, and it has a budget of 205 billion TL. And this is actually a pressed budget. The treatment services are generally done by the Ministry of Health and Public Hospitals. When compared, the costs is quite low when compared to the other countries. So under normal conditions, this should have been 350 billion. TL, and the medication system has a policy, and we implement this policy, and we have the cheapest drugs, medications in the world. When compared, almost we have the cheapest medications because of our system. Hospitals and university medication expenses are shown here in this graph by years, and I will skip those parts. Unfortunately, the numbers of the visits are really high. In 2021, there were some decreases. This is why I shared the data in 2019. So this is coming to the number of visiting and healthcare institutions per person. So in 2019, per person, this number was 10. And when compared with other parts of the world, our people, our society is able to reach the doctors very easily. And this has some negative sides, of course, and they reach different doctors, and they compare different doctors. And when they have different recommendations, they are confused. It is easy to reach. I don't think in any place in the world can go to the professor of university or research hospital. Even for a simple influenza, we can go to the professors. Unfortunately, this is the case in Turkey. Of course, this is not the correct method. It is increasing the costs, and it is also sometimes preventing those people who are in need to reach those professors or professionals. And I worked as a director general previously, and I experienced that, and I still experience things like that. People say that they are not able to find appointments for the doctors, physicians. The reason is this, actually. Everyone is trying to go to the doctors. Our physicians has a certain potential. They can examine 30 or 40 or 50 patients daily. After a certain numbers, we are not able to give open any new appointments, and those are living in the rural parts having a hard time finding an available appointment, and we need to have the referral chain, referrals. It is a must. I know that it is important to have this referral chain. As a country, when we are providing these healthcare services, we are not making decisions alone, and we have some different payments, and we have other line ministries, and we have a commission which is called Healthcare Services Pricing Committee. And we designate the prices, and payment rules and criteria are also published in the official gazette, and it is announced to the whole public. And you know this health implementation circular, this is called SUT in short, and you can see the general provisions and for the diagnosis, treatments, medical devices, medications, and invoice and payment. This was first done in 2000, and it was improved, it was developed, and this circular is transferred to the electronic area platforms, and you can control this data on the Medula system. For remuneration, we don't work together with the producers as a state. We worked with mediators. And when I was the Director General, and after that, I thought that this was wrong, because we need to work with producers, and if you do not have the contract, for example, there was an increase in the official gazette, and the producers stopped providing this service because there is no contract and directly with them. So our first contact should be the producers, in my opinion. In most parts of the world, for pharmacies, for medical markets, they use commission. This is like the cost of transfer of the medication to the patient. But in our country, it is not like that. We have profitability with percentage, and there are some negativities about this. Hopefully, from now on, things will be different, and these drugs, medications will be put into the market. When we have the profit margins, the mediators are storing the products because they know that the prices will be increased. But if we had used the commission, we wouldn't experience something like that. On the other hand, Ministry of Health and university hospitals are paid as according to what they need. And let's say that the hospital needs 10 million, we make an agreement in the beginning of the year of 10 millions. And this is without looking at, we don't look at their service production or other things. For private hospitals, foundation hospitals, we pay only for the services they provided. And these are the numbers of the hospitals and the pharmacies. These are the numbers from 2 years ago, but I don't think it has changed significantly. And for medications remuneration, in our country we have a very strict pricing policy, and we are the insurance is paying the drugs, the medications, and the prices are lower, and the producers realize that, and they are they're moving their drugs to the foreign lists. And when they do this, they also have a price advantage. The budget is about 700 billion with this new markup. Because of the strict pricing, One of the most important problem is that we are not able to bring new technology drugs because of the pricing, and the producers have R&D costs, and you know their first prices are really high when they're first put onto the market, and the producers are generally sending their drugs to abroad, to other countries. With biotechnology and biosimilar drugs, we can see the number of drugs, number of medications, and the amount of payments, and the rate is increased, as you can see. We had implemented a program of localization. This program was successful, really successful. However, after the second phase of the program, European and American producers filed a court case and canceled the program, and because they didn't want to localize here. And in the first two phases, we localized the generic products. There was not a problem. Our drug number is increased, but for the third and fourth phases, I can say that we were not able to do this. And biosimilar drugs, we didn't have any localization, but as a country policy, I believe it was really good, and we were able to produce, and we were developing. We need to develop the drugs and produce drugs and develop technologies. In 2019, you can see the cancer drug medications, the budget, and it's 2.2 billion was drugs, and the remaining part was healthcare services. Now we have this medulla system. I want to talk about this medulla system, and this is a software. We owe our success to this system. In 2008, we started to work on medulla for the first time. We were discussing whether we could be successful or not as the institution. But right now, we can say that we were successful, we've been successful. And I think that now, if it weren't for this system, 205 billion lira would be up to 300 billion, because the losses were decreased by 30%, and we started to use biometrics ID validation systems when we go to private hospitals, or when you come from abroad and go to a private hospital. To have a provision, we use fingerprints or hand prints. So no one can use their ID for another person, or it is not possible to open up a treatment card for a person who has not visited the hospital. And when we first started to implement this, there was a 10% decrease in applications, and it is now used actively. But in the developed technology today, they yeah, now we can have the Face ID. And SGK is institution, we've studied on this, but with the pandemic it was delayed. We can make it. We can decrease the cost and safer with the Face ID. It is widely used, and in all its stages, it can be used. When it is used widely, it can decrease the losses of about 10%. And we also have the Face ID's other advantages, like we can decrease the age 12. We can do this for the children too. Face ID can be done for them too. Yes. You can see the data. It is about 4 billion data daily coming to Medulla system. It is all recorded there, and maybe you heard that there were some mix-ups. When we prevent this with the help of Medulla system. And as a result of this system, we can follow up with those procedures which should be done once a year or once every 6 months, and so duplications are totally prevented. And in many tests, we were talking, we had some levels, some thresholds, you know. Yes, we can check it 5 times or 6 times. And now they are not able to repeat these kind of tests. And Medulla system has a cross check for the procedures, and I already talked about this SUT circulars. There are some warnings, like some says this procedures cannot be done, or this, even if it is done, it is not paid. They are going to be paid. And we have branch-based definitions. If this branch physician is not there, it cannot be done, for example, and this eliminates some problems because of human errors. And right now, I visited 20 European countries. I examined them, and they don't have such a large healthcare data registry system. And the program, we checked the sustainability of their program. We conducted some global risk analysis programs, and they did not see such a big data in any other country. I think the reason why this universal healthcare system was that successful was because of this software. 30% at least it was affected by this. Thank you very much for sharing your time, and thank you very much for your attention. Thank you for your presentation. Are there any questions or comments? Let's receive them right away. Thank you very much. I'm from Ministry of Health. I was the chair of Memursan and Sağlık, former chair of Memursan and Sağlık. The hospitals are integrated with Ministry of Health. And we had some proposals as trade unions, and this local drug industry should not be closed, we said. And there was also the foreign one, and we had approximately 80 drugs, and there are legendary drugs that, and we have antibiotics too, but unfortunately they're all closed now. What is their current status? I don't know. I'm working in Ministry of Health and I'm researching it, looking for it, but I'm not able to find anything about this. And we can bring that drugs, medications to the Turkey economy. They are using foreign drugs as analgesics or anti-inflammatories. First one is this. If we also said that if we're not going to build factories, especially for physical therapy, orthopedics, there were some production centers of the insurance system. We said that transfer it to us, but they gave it to Bilkent University, and Demirel gave it to Başkent University. And you can do it, do something similar to that for us, but it was not accepted. Do you have any knowledge about this? Thank you very much. The SSK licenses are still on SSK, Social Security Service, Social Security Agency. And when I was the Director General, I talked with the related institutions, and they said that once you have complete all the processes, your license will be renewed, they said. We didn't do anything, but all these drugs are now generic drugs. We have our local producers. I think biotechnology is important. We have small laboratories, in Turkey, and we should support them. And we have TÜSEP in Ministry of Health, but we didn't have any products from TÜSEP. So our wish is that hopefully TÜSEP will be used we will take the necessary steps in this path, because biotechnology and biosimilar drugs are important. And we have SMA, Zolgensma drug, and they want 2,100,000 USD for this drug. And maybe 10 years later we will talk about a budget which is 10 times or 15 times bigger than this budget, because we're focusing on the personalized treatments. And of course this is also about the generic drugs, but they will not be like 50 lira drug, they will be millions of dollars. So every country should develop their own local industry, drug industry, medication industry, and we need to work together with the academicians in this path. Thank you very much. Let's take another question from the venue and we will continue. Can we please give the microphone? My name is Dr. Ertuğrul. I have just started working in medulla, in prescription system. There is a recommendation about this substitute drugs, and it says that you can contribute to the state. I looked for them and I wasn't able to find those substitute drugs. How is there a reduction in the cost? So I don't know what to do about this. We have our drug lists, and if you check our drug lists, we have a covalency or substitution codes, and we recommend the one which has the lowest price. The program was recommended this to you, and the spectrum is now about 5%, and this recommendation is not quite meaningful. In the past, the spectrum was changing between 20%, 30%, but now it is 5%, so it is not quite meaningful. And sometimes you're not able to find it in the markets, and when it came to the 1%, it is in the when it is in the 1%, and if I don't know if you can find it in the pharmacy in your neighborhood. In the last month, as I said in the beginning of my presentation, we had some pricing issues, not the stocking issues, storage issues. But yesterday, there was a markup of 36.7%, and hopefully in the upcoming time we will be able to find the drugs easily. Thank you very much for listening to me. Thank you.
Yola.
Thank you, Mr. Özdaryo.
Conference, 7th World Islamic Health Union Congress in the capital city of Ankara. I'm pleasure here to be with Professor Ahmad Ural to chair the session number 2, Social Problems of Oncology, Patients and Solution. And let me invite the next speaker, Ms. Arzu Injadish, who is going to talk on the title of Psychosocial Problem of Cancer Patients and Their Relative and the Level of Burnout in the Family. Without further ado, please, the podium is yours.
Thank you. İsmim Arzu İnce.
My name is Arzu İncediş. I work as a social service expert at Ankara Oncology Training and Research Hospital. Today I'm going to talk about the psychosocial problems of cancer patients and their relatives and families' exhaustion problems and what we do against these problems. In my presentation, I would like to talk about the patient problems, and I will present a case example and the issues regarding the implementation in the field, and I will share what we do at the hospitals. As we all know, diagnosis is a difficult process for cancer patients, and it brings psychological, economic, and social issues. In the definition of health by WHO, there is also the definition of wellness in terms of psychological, economic, and social terms. And in our field, we would like to also support cancer patients to heal them, to help them heal in all fields. I've been working with cancer patients for 7 years, and from the research that I have done, I have identified some social issues. It is common that some individuals become distant in the family when they are diagnosed with cancer in an unexpected moment. They don't know how to behave. They don't know how to react, especially if women are diagnosed with cancer. Division of roles, division of work at home becomes problematic, and if the woman cannot deal with this domestic roles, the man has to take up more responsibility, and sometimes they feel inadequate. And social isolation is very common after the diagnosis. It really depends on their social environment. Our African professor also mentioned there's this labeling of cancer patients. Sometimes their relatives are so involved in the process, but sometimes they stay away from them and they remain in a social isolation. I have seen patients who stayed in their bedrooms for 6 months. And the patient may also have difficulty in maintaining their responsibilities in family and in society. The communication in hospital is also very important. The patient must have sound communication with the hospital staff and family, and they may have difficulty in prioritizing their life plans after diagnosis. So this also causes social problems. One of the most common issues that I have seen in the field is that they have anxiety of dependency. They don't want to be dependent on other people. They are afraid that they may not be involved in production anymore. Their professional, vocational performance may be affected by their illness. And if the patient works in a heavy industry and they may have to stay away from their work and they will have financial problems. I would like to give you examples from what a cancer patient said to me once. The patient says, "What is everyone going to say when I'm diagnosed?" And first I had this anxiety and I did not share the diagnosis with everyone, but I live in a small town and everybody heard about it. They didn't tell me that they knew, but I knew that they were approaching me in a different way than before. And another cancer patient with breast cancer told me, when I was first diagnosed, I thought that everyone would be isolating me and they would be treating me differently. My community is different from the others. You can have a heart disease, but if you have cancer, they assume that you are going to die soon and they treat you differently. And I will also talk about the economic issues. They can benefit from the general universal health care insurance, but there are many people who don't know that they have this right. And when they contact us, we inform them about their right to benefit from universal health care. And of course, they have financial issues because they may lose their job because of the cancer diagnosis. Ankara Oncology Hospital serves too many people from different parts of Turkey, and they also have the problem of accommodation, access to food, and the families with financial issues go through a difficult time if they have to travel from one city to another and they have to find accommodation and everything during the treatment process. This is a big problem in our country. Yesterday, we had an Afghan refugee, a cancer patient in a later stage. Her daughter can't take care of him because she has to work. She has to go to work. They have difficulty paying rent, and their only income is the social aid they receive from Red Crescent. And although he is very ill, they can't benefit from disability rights. And these are some fields that we have to support. And there is a research by the Turkish Cancer Society. 80% of the people who participated in this research, 80% of all cancer patients are having financial difficulties. Only 20% say that they can afford the treatment and everything. And some are supported by the foundations, by charities. And 25% of the participants of this research said that they received support from other people, and some of them said that they had to change a job to afford the cancer treatment. I have another case here, 42 years old, metastatic breast cancer. She's a homemaker. She was married when she was 14, and her treatment, she had a baby. 20 years later, she had 4 pregnancies. Her husband works in construction fields, and he is paid on a day-to-day basis. He doesn't have a stable income. So in this case, the most important problem was the negligence and abuse of the children, because there were children at home, and when the mom goes to hospital for treatment, the children are alone at home. When I visited their home, I saw that they didn't have enough beds to sleep on. And of course, it's problematic for a cancer patient to be treated under these conditions. How she can heal. And in order to reach the hospital, she had to take 3 different types of transportation. There is no support from the extended family members. They cannot afford it either. We have a store for support, for in-kind contribution to cancer patients. The municipalities are making contributions. So in this case that I mentioned, we provided beds and furniture to her home, and we contacted Altuntaş Social Service Center, and they supported children financially. Unfortunately, we lost the patient, but this family is still living on the support that we provided during that period. And we also register children in the kindergarten, and we try to solve other problems of the family. For social aid is very important in terms of solving the social problems of cancer patients, and social services provide a buffer in terms of supporting the wellness of patients, and we help them to develop positive attitudes, and we help them cope with the situation. No matter what medication you give to the patient, if the patient is not ready mentally for healing, that patient may not receive any benefit from the treatment. And there's also empathic, emotional support, informational support, and these are types of social support. The most important support is the support from relatives, from family members, from neighbors, social environment. And of course, there are different types of social support, such as charities, social service experts, psychologists at hospitals. So what can we do? We can share the sadness and anxiety of the patient and the family members. We must inform the patient and the family about the disease, about the treatment process. When the patient does not receive enough information about the disease, about the process, they have more anxiety. So when we provide that kind of support, we can support them better. And in order to make them busy during their free time in the clinic, in the hospital, we provide them with free time activities such as painting. And we also relieve them with motivating speeches, and we try to provide support to family for other issues that they have. And we can give them transportation support. There are social support centers in Turkey, and they take part in this process. Maybe we can make it possible for the patient to communicate with other patients, so they can receive from other patients too. So what we do for support, some patients have accommodation problems. Municipalities have free of charge accommodation possibilities. We refer them to these centers. There are cash and in-kind supports. So we communicate with the centers that provide such supports, and we make possible for the patients to receive them. I work in the Oncological Support Center. We have a freezer. People always donate meat. It's never empty. There are people who provide contribution, and we also do information sharing, awareness activities. We provide counseling, and social activities are also organized at our center. You can see the pictures. This is our cancer patient school. Every day, we discuss important issues regarding the cancer treatment, nutrition, and such. And we also organize cancer days in order to raise social awareness. And we want to include patients who are socially excluded, who are isolated. This was an event we did in 2017. We organize informative conferences. We take our patients to movie theaters. We went to tree planting activity. And this is the craft therapy center. And when they come to the center, they know that they can produce something. You can see in the pictures what our patients did. They are working on crafts. And this is the shop that we have at the entrance of our hospital. And we established this shop with the support from the Red Crescent, from clothes to cleaning supplies. We have everything. Motivation is very important for cancer patients. It's a dream for many people to visit Mecca, to have Umrah. And in order to provide hope for our patients who wouldn't even dream of it, we have made it possible for 7 patients to go to Mecca. And this is a picture from Medina. The one on the left. We lost this patient after 2 years, but she was really grateful. Cancer awareness events. We also try to raise social awareness for the cancer, and we try to provide financial support for them with these events. And there are special programs for the children. These are for cancer patients who are children or the children of the cancer patients. There is another activity for the education support, and we work with a charity. With this charity, we had special backpacks filled with supplies, and they took them for cancer patient children. And this is a care center for children. They can drop their children when they need to. This was a project from 2018 with the support of the Red Crescent. We can do great things if we try. It's really important to work with civil society organizations, volunteers, municipalities. LSEMA and Turkish Red Crescent have worked with us. I would like to thank them, and I would like to thank you for your attention.
Any questions from the floor? Yes, please.
My name is Metin Gürsan. I participate in this event from Istanbul. I represent Istanbul. I would like to thank Ms. Arzu, and she has been working in a very important problem for the society. In our cancer-related work, I know that there are some issues in the field, especially regarding the dental procedures of cancer patients and surgical processes of cancer patients. There are some problems in the field. As I was working at Istanbul University, I saw similar problems. I would like to touch upon a very important thing, and in Turkey, cancer patients should be also receiving dental oral procedure support, dental treatment, surgical treatment, and they should be supported with treatment by an ENT. Thank you again.
Any other questions? There's a lady in front here.
First of all, thank you for touching upon very important issues. We know that the relatives, families of the cancer patients are affected by the situation highly. I participate from Kocaeli. I work for a civil society organization, and I believe that the financial support given to the parents, especially if they have a children who is a cancer patient, should be increased. When I went to France, I saw that they support them with religious support, depending on their religion, with hahams or priests. In Turkey, I think this is missing. Maybe we can do something. Our Mr. Qasim is very active in that field, and I want you to be involved in that field too. I work at Ankara Oncology Research Hospital. What you mentioned is very important. As I mentioned in my presentation, for a holistic wellness understanding, it is important to support the patient in every way. We had a project with the Religious Services Department, and we have a colleague working at the Religious Support Department, and during the palliative support, they pray for the patient at the hospital. Of course, you can request to be included in this project, and during the past few years, we have psychologists, social service experts, and we also have religious support experts. Thank you very much, Ms. Arzu. I was really excited to see the work that you have done. I participate from Ertuğrul. My name is Hilmi Yabelioğlu. As a volunteer in a civil society organization, I'm also coordinating the national efforts in the civil society organization. I would like to make a recommendation to you. I saw that all your work is centered in Ankara. Is it possible that such activities should be spread to other parts of Turkey in order to raise awareness and support the cancer patients? I know that Cancer Awareness Day is celebrated all around the country. So is it possible to spread this volunteer work to every part of Turkey? Unfortunately, well, you know, in every profession, there are people who do their job eagerly, but there are some who don't. And I mentioned the resources that we work with. in none of these activities, hospital budget was used. I have dedicated myself to cancer patients. I did not have the time to share every work I have done. In October, I took cancer patients to a healthcare camp to Afyon. We did breathing exercises, karaoke, parties, and there were patients who have never been to a hotel before, and I want to make these available all around the country. Of course, I cannot afford to do this for everyone, but what I can do is that I can talk about what can be done, but I hope that these efforts will be widespread. Of course, we will be happy to have you in our city. I am a national coordinator of a civil society organization, and there are people in my city who take care of 270 orphan kids, and they try to provide support and include them in the society. Of course, the most important one is the human resource. Voluntary work is important. We have worked gradually, and we have gone over some obstacles. And there have been people who saw our work and they supported us. We have made it possible for the families to be included in the society, and the real deficiency is not the money. They lack the love of parents. And for the cancer patients, what's the name of? I hope that civil society organizations would be supporting this aspect of the problem too. That we have representatives and managers of civil society organizations. Of course, I gave an example from Ankara, but we have patients from smaller cities, Van, Hakkari, Uşak, Denizli. We have patients from every city. And I'm trying to use all the resources I have for the cancer patients, but individually, there's an extent of the support that I can give. We need to create sensitivity, awareness in the society. If I didn't do this presentation, maybe people wouldn't think about this. Of course, we need to provide opportunities for these civil societies. And you also emphasized human resource. That's also important. And I recently started working with LÖSEMA, and we were also doing live broadcasting for the cancer patients. And there are many cancer patients who contact me through the districts chefs, and I try to help them all. Of course, the social awareness is the most important. I hope so. Thank you. Thank you, Ms.
Pleasure of calling upon our third speaker, Dr. Zahra Ali. Dr. Zahra Ali is going to present a title, Access to Diagnostic and Therapeutic Facilities in Africa. Without further ado, Dr. Zahra Ali.
Yes. Thank you very much for inviting me and for giving me the opportunity to be able to be with you today. As you said, my name is Dr. Zahra Ali. I'm joining you from Kenya, and it's really a pleasure because I thought I was not going to be able to get to you. I'm not a direct oncology or cancer specialist, but I'm also a psychosocial specialist, also trained in Turkey. So I really resonated with Ms. Arzu, and I was so happy to hear of all the efforts and whatever they have done in Turkey. I hope we'll be able to collaborate together. Today, I would like to share with you as like a brief summary of the accessibility and availability of cancer diagnostic and treatment centers in Africa. I will be mostly talking about South Africa, mainly in Kenya and a bit of South Africa. Cancer has become a major problem in Africa, and some people say it is a major problem because of the availability of a bit more of facility for diagnosis, but others also say that it is because previously we were more concentrated on infectious diseases and pandemic effects or like such. In 2012, we see that we had around 847,000 new cases of cancer, but it is projected that by 2030, the figure will go above 1.4 million. Right now in Kenya, we have around 46,000 cases per day. Can you hear me?
Yes, we can hear you.
Okay. Sorry for that small technical issue. As everyone knows, just like in other places in the world, the largest cancer cause or killing cause in Africa is cervical cancer. And just as our sister here has mentioned that there is a lot of stigma, so many people don't go to hospital on time, even if they are aware of the symptoms, they don't go to hospital on time, and they end up being diagnosed at a later stage. And this is a very big problem. Now, with accessibility of the facilities around, we find that one of the major problems is there is a shortage of appropriate cancer diagnostic and treatment centers. And we also have a very small amount of trained personnel in Africa. In addition, our governments really invest in very small amounts. We have, for example, in Africa per capita, the amount is only $82. So this is a very big problem. And patients, once they are diagnosed, they are forced to pay out of their pocket, and many patients cannot afford the treatment. So you end up having the patients either going for half treatment, or they are not going for the treatment at all. After a few numbers, they don't go for treatment at all because they cannot afford it. Also, our health systems in Africa, unfortunately, are not like in Turkey. I really appreciate that health system in Turkey, and I've been through it, I know it. The referral systems are not good. It's only in a few places in Africa where we have family doctor system who can know the whole family, who can be close to the family, and who will be able to diagnose, to make early diagnosis. Next, please. Next. Yes, in Sub-Sahara, you will find most of the countries do not really have a direct access to the necessary treatment methods and treatment equipments. For example, radiotherapy. Only a few less than 20 countries have access to this. And only 10% of patients in low-income countries, which most of Africa, unfortunately, is composed of, although we have a lot of rich people as well, and have access to radiotherapy compared to the rich, high-income countries, where the amount can go up to 90%. 19 of the 20 countries recorded as having the highest cervical cancer burden in the world are in Sub-Sahara. This will give you a very open picture where you can see the situation is not very good when it comes to cervical cancer. Through cancer care, although cancer care and the systems in many of the African countries now have been improved, we still have a lot of challenges in prevention, detection, and treatment services available because mostly we have financial hurdles, we have financial limitation, both for the governments as well as for the patients. And you find that despite all this, we have some large institutions, organizations in the world, like World Health Organization, and we have for IAEA associations which go ahead and they have assisted Africa in changing the systems. One of the examples I can give is in Kenya. In 2017, we had only 10 cancer centers. But today, Kenya has got 46 counties, which are like states, and every county has got a referral center where cancer can be treated and the patients can go. In addition, all the major cities have private associations, private hospitals, and private institutions who offer cancer therapy, cancer diagnostic and cancer therapy. So you find that even though we do have all this, we still have a number of countries without appropriate infrastructure. They don't have the appropriate laboratories. They don't have the appropriate trained human resources to be able to serve the people. Even if they have some trained human resources, you find that these human resources, the trained personnel, cannot find an appropriate environment to work in, so they tend to migrate to other places where they can be of use and they can utilize the training they have had. So there is a lot of deficits in the existing oncology workforce, which needs to be increased. Yes, please. Next. Next, please. Yes. As I said, we have problems with the affordability of the services and medications. This is because most of the governments have not allocated appropriate budget for health systems, leave alone for oncology patients and oncology management. The governments don't have the money, and the people in total, especially after the corona pandemic, losing jobs, losing their main livelihoods. We have a lot of problems economically. But slowly by slowly, with the recovery of the pandemic, people are coming back, getting some businesses. And also, Corona introduced us to a lot of other means of getting finance, which people are now using to get money and to be able to treat themselves. Cancer treatment is very expensive. Unlike in Turkey, whereby they get assistance from the government, I don't know any African country which has got 100% assistance from the governments for cancer treatment. Even in Kenya, whereby we boast of a better system than most of the African countries, apart from South Africa, you find that we also cannot, most of the people cannot afford to be able to pay for cancer treatment all the way through. With this, we need to find means and ways to change and to revolve our health systems to be able to meet the needs and to serve our people back here in Africa. And the only way we can find this is to be able to increase the resources. Okay, you cannot increase all the resources physically, but we can go into consortiums, we can go into partnership, local, continental, and global, and this might help us go through. And also we can have more awareness programs. With sustainability of the cancer facility treatments, you find that, again, because we don't have the money, we open up some centers, we don't have enough equipment. Even if we have the equipment, We don't have that trained personnel to run this equipment, to run the tests. We don't have the appropriate laboratories. But we need to increase these facilities all over Africa. Go back, please. Go back, please. Sorry for that. Go back, please, to the previous slide. Son slide geri dönebilir misiniz lütfen? Okay. We need to find means of getting. Sorry for that. We need to find means of. Excuse me. Okay. We need to find means of getting appropriate facilities, getting appropriate local human resources, the capital for the centers, and to be able to get all the medications. Now, for the health service providence facilities, policies, Kenya is ahead. Kenya and South Africa are very good. We have countries like Nigeria, like Ghana, some countries coming up in the northern of Africa also are really coming up with policies, good policies for local implementation. We have training in many areas in Africa right now, including Kenya, again Ghana, Nigeria, a bit of Brazzaville, and also in Zimbabwe. Not forgetting South Africa, which was well ahead of the continent quite some time back, and it even offered training for other African citizens. We still need a lot of training, as I said, for local resources. I'm very proud to say that in 2016, there, Kenya was being ranked as 11th for providence of health facility, but today, as of today, Kenya is ranked second as a health hub to assist all over, to provide services to people at affordable prices, and also with good facilities in exchange, instead of going to India, to Europe and to other areas. Availability of medications is still not very good. We need to come up with our own production, just like Turkey. We need to copy a lot of things from Turkey. We do have equipment production in Kenya, which is mainly on the physical ones, like the beds or the chairs and such kind of furniture, medical furniture, but we don't have pure treatment equipments being produced in that country. This is something which we need. For example, oncology patients might need a lot of oxygen. We don't have the appropriate oxygen providing facilities, and this is just a new subject coming up. Unlike in South Africa, or unlike in Turkey, where there is a lot of equipment and a lot of appropriate mobile facility which can be used. Yes, please. Go ahead. Now, what can be done to improve accessibility for diagnostics and cancer care services in Africa countries? Now, the first one is our financial problem. The financial problem, according to some research and according to the experts, which I also support, can be done by partnering up with appropriate government, non-government, and other institutions, research institutions working in this area. This will mean the governments will deliberately invest in the government's health systems, and they will be able to open up some collaborations. For example, the African countries can very easily partner up with the Ministry of Health, which I'm very much aware Ministry of Health of Turkey has been providing training for a number of different sectors in the health, of different departments in the health sector, but maybe we can push up for oncology as well, and this would be a great thing. In Africa, for example, there is a paradigm. We need to have a shift. Please go back. We need to have a shift please go back to the previous one. Previous one, please. to the previous one. Önceki slide. Yes. We need to have a paradigm shift in the approaching of the governments to the health system, not taking it as an expenditure, but taking it as an investment. So it will invest in the infrastructure, it will invest in the people, it will invest in the manufacturing sector for oncology and for other medication. And also when we partner up with other sources, we can have a lot of support and reduce our costs to meet some of these expenses or some of these needs. For example, in Europe and even in Turkey, I know very well that whatever laboratory equipment is used, after some time they have to change. This is a policy in Turkey. They have to change the laboratory facilities and the equipment. So if we can partner up with Turkey, Turkey would be able to donate this kind of facilities which are discarded for new technology, but still in very good status, which can be used in Africa. And they can do this through training programs together, through research programs together, so they know what is needed in Africa, and the Africans will be able to know what is available in the market in Turkey. I'm talking on the governmental side. The private or the NGO side can also collaborate very closely to be able to handle some of the issues. We will need to have community awareness. In Africa, we don't have enough community awareness. We need to train our people much more on what is cancer, how to prevent cancer, how to be able to identify any signs of the cancer, and in that case, reach as fast as possible to facilities where they will be tested, and they will be able to have early diagnosis. That means early treatment. Most, like cervical cancer, is a treatable disease as long as you reach it early. And that is important. We will need to have integrated approaches for the cancer care systems or the cancer care providers, whereby we can use whatever facility we have in a very efficient way, instead of everybody trying to do or to be on their own. Cancer treatment needs to have teamwork, not individual. Talking of teamwork, we will need to come up with facilities or with institutions which are not available in Africa but available in, for example, in Turkey. I'm a psychosocial specialist. I remember very well when I came to a home and I went to the medical board and I presented myself as a psychosocial specialist. I was told, doctor, sorry, you have to forget that department. We don't have it here. When it is working very, very well. Everybody knows that half of the treatment for cancer patients is mainly psychological. So we will need to boost it up. Yes, very beautifully. In Kenya, we do have a lot of survivor programs, people training and people sharing their cases and also supporting each other psychologically. But we do not have enough institutions, enough groups or enough facilities to be able to provide this psychological support, not only for the cancer patients, but also for their family in large, which is affected. And I think we who can be a platform whereby we can share or come up with a psychosocial support or an oncology structure, which Dr. Metin has also mentioned, and also just as has our sister Arzu, Miss Arzu has mentioned that we can collaborate together and be able to assist each other. Then the Islamic world will be in a much better position. We will be able to share a lot of information, a lot to exchange training, to exchange personnel, to exchange the know-how. And also we as Muslims need to go into Tibbi Nabawi to be able to see the Islamic aspect of how they were treating cancer and scientific and publish results, publish researches on this thing, and so that it is able to be managed, so that we can have an entity to which will come just like the modern medicine, to be able to grow this thing. Right now, most of it is hijama, but apart from that, we don't have much of the TB Nabawi, especially in the treatment of oncology. We don't hear much of it. So with this, maybe I should talk of what is the future for Africa apart from all this sharing, collaboration, exchanging of information, exchanging of know-how. Maybe we could come up with the university departments whereby the oncology and other medical health providing departments will have twinning programs between universities in Turkey, in Africa, and this will help us improve. But we also need to collaborate as Africans among ourselves, because we have a lot of beautiful scientific research actually being done in Africa, but it is not being published. It is now that the platforms are coming up, like Africa Association for Cancer is coming up. And we have other associations ready to provide the platform, but these are very new. So we need to collaborate with them. We need to look for them and to be able to continue with the treatment and the training of the personnel. We need to have manufacturing of the cancer medicines and cancer needed equipment for treatment, equipment needed for treatment. So I would request those who are already doing it in Turkey, which I know they are there, to please get in touch with some of us, get in touch with some associations in Africa. Maybe we could coordinate this, or we could have another coordination team. It's just a suggestion. And we could be able to open up, because Africa is opening up. After Corona, Africa is really opening up in many aspects. We are improving in our communication skills. We are improving in our perspectives of training. We have a lot of universities in Kenya which have opened up oncology departments and training. And this could be chances for us to exchange training and to be able to strengthen our bond between the Muslims, between the Africans, between Turkey, Malaysia, I know is also very good. Indonesia is very good at that. So this could be a way of strengthening each other. Yes, we also need, please go to the last slide. Last slide, next. Yes, thank you. Yes. Yes, thank you. We need to have priorities in Africa to develop a number of sectors, a number of departments. We need to increase the molecular biology and genomics of cancer in Africa. We need to increase epidemiology, and we also need to increase the behavioral studies and also to assist the people, because most of the Africans are now getting cancer because we have urbanization. People have moved to the cities. People are no longer active as before. People are no longer eating organic food as before. People are just eating processed foods, sitting, becoming potato coaches or computer wizards and sitting in front of the computer all the time. We have a lot of pollution in the air. We need to be able to treat this. So all this would come under epidemiology, clinical studies, trials of treatment and interventions for the cancer in Africa. Of course, we need to increase the basic science studies on biology of racial disparity, as well as to increase cancer survivorship mortality and to reduce the burden of cancer, and also increase the awareness and the importance of having cancer screenings in Africa. This should go in line with the training, starting from primary school, going secondary school, high school, and in all the way to the universities and public institutions, or public service providers. Yes, with this, I thank you very much. There is a lot to be talked about in Africa. I thank you for listening to me. There's not enough time, but I would like to leave you with one video. I hope our friends will be able to play it. one video which is showing an example of not only behavioral change and awareness, but also how we can help our local people in Africa be able to meet the expenses of the cancer problems once they get it. Hoping all of us have a very healthy life and a very successful and fruitful collaboration. Thank you very much for giving me this chance. Thank you.
Çok teşekkür ediyoruz Zehra.
Thank you very much, Zehra. I think there is a video. If you can turn it on, let's watch it. We can have maximum 1 or 2 questions. We are extremely delayed. If there are any questions or comments, we can receive them. When we visit African countries, hello Zehra, hello. We know her when she was a student, when she was in Ankara. We used to meet, and this is a great surprise to see her here. We visited many African countries, and we saw that in the world there are many medical instruments that are sent to Africa. But when there is a problem, then they are put into a storage. When I go to an African country, we visited a lion hospital, and there were some materials, laboratory materials, which are not even found in Turkey, and in a large depot storage, these devices were broken, and repair and maintenance is one of the most important problems of Africa, and of course the trained human resources are going to Europe. This is another issue. Thank you very much. It was great to see you. Can you give the microphone to Metin? Zehra, my name is Metin from Istanbul. You said that 300,000 women are losing their lives because cervical cancer. Am I right? Was it correct? Yes, unfortunately it is correct. And this is because late diagnosis, and they come in the later stages, and it is generally too late. We are not able to treat them at all, or Arzu Hanım said there are some cultural stigma issues. They don't want to talk about this. They feared about talking about this cervical symptoms, and they don't come to hospital, and they lose their lives because it is too late until they're diagnosed. So increasing awareness and trainings for awareness increasing is really important. We should provide these trainings in the primary education. Thank you very much. This was a great presentation. You talked about molecular biology, and you talked about awareness training. And Professor Ertuğrul is now in Bolu University. He is our moderator, and when we conduct a study for Africa as VIHU in Bolu, Bolu gave us a great opportunity, and I want to give the good news to you. They allocated 20 beds to us, and then we connected with Bolu. And in Bolu, in the university, we can start this awareness raising studies. I wish you the best. I wish you success, and I would like to congratulate you in the name of all African Muslims. Thank you. We will not see the video presentation. If you give me 2 minutes, we are really delayed. We have a problem about timing. If it is not quite critical, is it possible to cancel it? Yes, it is okay. It is okay. No problem. Thank you. I would like to thank you very much for this valuable presentation, and I will finish this session. Thank you very much for your participation.
Sağ olun, görüşmek üzere. Herkese sağ olun.
daha var. Onun için çabucak ben başlatıyorum.
I would like to start the session if you allow me, distinguished guests, distinguished President. I would like to salute you all with my deepest respect in our third session. We are going to moderate with Dr. Ahmet Fevzi Özbey. He is one of the first persons who involved in the efforts to ban cigarette smoking and restriction of smoking in Turkey, and he started the first efforts in Turkey, Mr. Ahmet Fevzi Özbey, and I was his assistant. He was a congressman at the point. The relationship of tobacco and cancer, healthcare literacy in prevention of cancer, tobacco control program will be discussed today. And Dr. Cecilia Roni will talk about the, prevention of cancer. Professor Dr. Toker Ergüder. Do we have the professor here, or are we going to connect to him through internet? Okay, let's move on to the next presentation. Dietitian Hava Balar Gezgüç. Is she here? There's another session after this one. Let's just hear a summary of what she would like to say. Dear moderators, distinguished guests, I would like to salute you all with respect. My name is Hava Balar Gezgüç. I have been working at Ankara Oncology Research Hospital as a dietitian for 11 years. I would like to talk about nutrition advices for prevention of cancer. I hope this will be fruitful for everyone. Nutrition, alcohol use, obesity, and physical activity are important factors in the emergence of cancer, and it is accepted that these are the risk factors that increase cancer more. Healthy nutrition suggestions decrease the risk of stomach, cervical cancer, esophageal, colorectal cancer. According to different resources, the correlation between cancer and nutrition is between 10% to 70%. There are some foods that cause cancer, and there are foods that prevent cancer. They have different impacts on cancer. And according to World Cancer Research Fund, American Cancer Research Fund, becoming fit in the ideal weight limits, consuming fruits and vegetables are among the prevention methods. I would like to touch upon the relationship of food types and cancer, carbohydrates and cancer. Carbohydrates are the basic nutritional food that we provide our energy from. We must be careful with the simple sugars. Consuming foods with high glycemic index and with simple sugars increase the risk of cancer. Of course, we can't say that simple sugars cause cancer, but they trigger the insulin production and they increase the risk of cancer. Proteins are another food group. If we increase the animal protein intake energy is increased, and it also affects the cancer risk. Stomach cancer risk is increased in those who are infected with Helicobacter pylori and who consume processed meats. Research suggests that if people consume more than 160 grams of processed meat and red meat, in comparison to those who consume less than 20 grams, the risk of cancer is increased by 35%. And in terms of fish consumption, the cancer risk remained the same in comparison to consumption of fish of more than 80 grams. Consuming fish decreases the cancer risk by 31%. Consumption of lean meat without fat does not decrease the risk of cancer. And when we look at the relationship between fats and cancer, not only the amount of fats, but also the type of fats are effective on cancer risk. And the research shows that omega-3, such as DHA and EPA, have an impact on protecting us from cancer risks. Squalene, that is a hydrocarbon that is found in olive oil, it decreases the risk of cancer. Of course, it is also effective in decreasing the respiratory system cancers. The research suggests that consuming fats and dietary fibers have an impact on cancer. Vegetables, fruits, and carbohydrate types, fibers, should be consumed for decreasing the cancer too. And we need to consume 25 grams of these every day. Foods with high fibers also include phytochemicals such as lentils, and they are also protective against cancer. These phytochemicals create a synergic energy against the cancer. Any increase by 10% in fiber consumption leads to a decrease of 13% in cancer risk. Any increase of 8 grams of fiber consumption leads to an 8% decrease in cancer risk. There will be another presentation on vitamins, but I would like to once more touch upon this. There's more and more research on vitamins' protective impact against the cancer, especially C, D, E, vitamin C, D, E. According to a research on vitamin D by the International Cancer Research Center, there is a reverse correlation between vitamin D and colorectal cancer, carotenoids, vitamins B9, C, D, E, B6, selenium, and phytochemicals can decrease the risk of cancer, and also carotenoids, lycopene, vitamin C, and vitamin E are protective against the cancer. And nutrition high in vitamin C also protects from stomach cancer. The recommended amount for the adult individuals is the consumption of 5 helpings of fruits and vegetables. Curcumin, resveratrol, and isocyanates. These are natural bioactive components, and they have protective activity, cancer protective activity. However, the research suggests that overconsumption of them increases the risk of cancer. Unfortunately, a lot of people use these substances in an uncontrolled way, and the vitamins should be received from the food, not from supplements. The research done in the past 10 years about alcohol and cancer proved that alcohol is a risk factor, and lifelong alcohol use is effective, but the cut of alcohol use leads to a decrease in the risk. International Cancer Research Center suggests that ethanol and the consumption of acetaldehyde is cancerogenic for people, and there is no significant difference between any type of alcoholic drinks. When we look at different sexes, and alcohol is risky for the upper respiratory system and stomach. It's from 25% to 44%, for liver from 18% to 33%, from colorectal cancer is 4% to 17%, and research suggests that use of alcohol leads to breast cancer. For the European women, an increase of 10 grams of daily alcohol use leads to 3% of cancer risk. Obesity is also a cancer risk. Lack of physical activity, a sedentary life have a higher risk of cancer depending on the type of cancer. Being overweight and obesity leads to breast, colon, endometrium, kidney, esophageal cancer, pancreatic cancer, liver, and ovarian cancer. According to research conducted with more than 7,000 women who are above 65, the weight leads to decreasing the weight leads to a difference by 25 to 40%. So in every age, weight leads to an increased cancer risk. Additives are added to food to protect food in for longer times and to make food more attractive to consumers. In meat products that are processed with heat and sold with additives, are proved to cause cancer. Some color additives are reported to cause thyroid tumors, chromosome damage, and aspartame, acesulfame, and similar additives are reported to cause cancer, and they also cause metabolic damages. So the consumption amounts should be controlled, and the risks of additives should be considered. It's really important what we eat and how we consume them, but it's also important how we prepare the food, how we cook or preserve the foods. If we use high heat in cooking foods, we create carcinogenic components such as heterocyclic amines. These are created in direct exposure of beef and chicken meat to fire. In order to decrease the emergence of these harmful substances, we must prefer baking or cooking in water. We should not expose the food to high heat for a long time, and another component that comes out when food is smoked and when the meat drops on the coal, they are exposed to polycyclic aromatic hydrocarbons, and this substance can enter all body tissues that have fat, and they may also cause skin cancer. Decreasing the direct exposure of food to fire or using smoke filters, smoke generators can help. We should not use the cooking oil more than 3 times. Burnt oil has cancerogenic substances. So how do we decrease the harmful impact of these foods? We can maybe consume antioxidant food with meat that is cooked that way, such as vegetables, so we can benefit from anti-carcinogenic components. And there are also microorganisms which produce toxins in nuts, fatty seeds, and such as aflatoxin, and they may cause esophageal and liver cancer. We should not preserve yogurt, tomato paste, or marmalades or pickles in boxes of detergents or metal boxes. We should prefer glass boxes. Thank you for your attention.
Suali olan arkadaşlarım.
If you have any questions, do we have any questions from the floor? So how do they cause cancer? Some of our patients also asked the same question. As my colleague Arzu mentioned, we have a cancer school project. Some patients tell us that I consumed organic food, I consumed healthy food, and there's this other person who consumes unhealthy food, and we both have cancer. I wish we could know the reason. I wish nutrition could be the only factor that could control cancer. But I always say that if you consume healthy food, you will see the difference. If you are diagnosed with cancer at 40 years of age, then if you did not consume healthy food, you would be diagnosed at 35. Of course, they see the impact of healthy food consumption in treatment and healing process too. Of course, there are some factors that we cannot change. We can't change the genetic factors, but the use of alcohol, tobacco, and food consumption, these are the factors that we can change. So we always say that the impact of nutrition is about 35%. We have to do what we can do. I would appreciate if you could maybe mention water. It's contained in plastic. I had to summarize my presentation because of the time restraint. Water is very important. Water is a cleaning agent that we use to clean everything, but it cleanses our body too. And consumption of water decreases the risk. In cold weather, we must drink from 8 to 10 glasses of water daily, and when the weather gets hotter, we should drink up to 3 liters. Thank you. Thank you. We have the time restraint, so thank you. As this was a very broad, extensive presentation. Thank you for your contribution. Professor Dr. Toker Argudar, he was going to do his presentation first. He is a colleague of mine from '96. I was a senator from Tokat province of Turkey. The first thing I did was to work towards the ban of cigarettes during my term. We were the leaders of that movement, so I'm really proud of that. As my colleagues mentioned, tobacco products, including cigarettes. Of course, there are other types of tobacco products. Play an important role in the emergence of cancer, and smokers are included in the high-risk groups. There's a research done in the United States. They compared those who smoke up to 40 cigarettes a day for 40 years. The risk of their developing cancer is 80%. Their risk is so high. Of course, sometimes people say, my uncle, my grandfather has been smoking for many years, and there's nothing wrong with them. Well, these are exceptions, and they cannot prove anything with those small exceptions, and we need to keep our youth away from the cigarettes. My colleague was going to mention this if he was with us, and I just wanted to summarize what he wanted to say. So next presentation is about natural products and antioxidants in cancer prevention. Nursuhana Omar, do we have her here? No, she's not here. So I would like to invite So we have limited time. We have a recording of her presentation, but maybe we can have a summary of her presentation. You can cut some parts of the presentation to make it shorter. Thank you.
Can I start now?
Yes, yes, we are hearing.
Okay. Okay, Assalamualaikum and could
Merhabalar. Öncelikle beni bu prestijli konferansa davet ettiğiniz için teşekkür ediyorum. Burada sunum yapma imkanı verdiğiniz için teşekkür ediyorum. 7. Müslüman Topluluklar Kongresi'ne davet ettiğiniz için teşekkür ediyorum.
Malaysia. So my topic for today is the natural products, antioxidants in cancer prevention. So this is my outline for presentations. I will cover overview of cancer, how and why people get cancer, what is natural products, what is honey and why is it useful against cancer, and a little bit in research on honey. So we go to the first slide. So the data from the Global Cancer Observatory 2020, cancer is known as a global epidemic, is a leading cause of death worldwide, accounting for nearly 10 million deaths in 2020. There are more than 200 types of cancer, and the 4 most common cancers occur worldwide are lung, female breast, colorectal, and prostate cancer. So according to the worldwide predictions, there will be 27.5 million new cases of cancer each year by 2040. So this slide shows that the number of cases of cancer, all cancer in 2020 in both sex and all age, show that the Asia is the largest populations that the number one of having cancers. So we go deep for Asia. In Asia, the number of the number one cancer in Asia is due to lung cancer, followed by breast, colorectal, and stomach cancer. So we go the comparison between Turkey and Malaysia. For the Turkey, according to Global Can 2020, the number one cancer in Turkey is due to the lung cancer, while in Malaysia it's suffer the number one due to the breast cancer. So we move to the next subtopic, which is how and why people get cancer. Cancerogenesis is a formation of cancer, multi-step process, and has multifactorial causes. Among the causes, there are due to low immune status, chronic infection, chronic inflammation, chronic non-healing ulcers, obesity, and diabetes. The carcinogenesis is actually a multi-step process which is occur in early stage, which is benign, and later on go to malignant, and it's due to a multiple risk factor. So this slide shows us that there is a multiple risk factor for the cancer development, and the first 1/3 of this risk factor is due to obesity, diet, and diabetes, followed by tobacco use, and followed by others which are chemical, carcinogen, environment factor, infections, and also alcohol overuse. So let's move to the natural product, which is I was actually in the USM. Doing my research is basically based on natural product and antioxidant. So natural products are considered as a rich reservoir of bioactive compound with therapeutic potential for their numerous health benefits. It has been reported to be multi-targeted in their mechanism of action because of their robust phytochemical compositions, thus making them more effective compared to the conventional medications. In recent years, there is a number of natural products that isolate from herbs has been found that inhibit proliferations, induce apoptosis, suppress angiogenesis, retard metastasis, and enhance chemotherapy, exhibit anti-cancer potential both in vitro and in vivo. So these natural products are also reviewed for their therapeutic potentials, include flavonoids such as from honey, alkaloids, terpenes, quinones, and saponins, which are isolated from medicinal herbs. In a recent study, the use of honey has excellent anti-cancer drugs in review. So for this talk presentation, I will go deep on honey because in USM we have established a research cluster in honey and produce a multiple publications towards the honey research. So honey, let's move on to the honey. This is in this picture show varieties of honey that has been used for our research. Honey is known for the centuries for its medicinal and health promoting properties. It contains various kinds of phytochemicals with high phenolic and flavonoids content, which contribute to its high antioxidant activity. Agent that has strong antioxidant property may have the potential to prevent the development of cancer, as cancer had a free radical and oxidative stress that play a significant role in induced the formations of cancer. So we need the antioxidant property to prevent this development of cancer. So this is the compositions of honey, which is contains a high antioxidant activity due to phenolic and flavonoids content. Honey also have natural water and sugar, besides also contains vitamins and minerals. So why we said that honey is a good against cancers, because the scientific evidence from our research show that honey is a natural immune booster, is a natural anti-inflammatory agent, is a natural microbial and fixer for chronic ulcer and wounds, is possible agent for controlling obesity, and honey for the 6 and 7 is honey is possible natural cancer protection and also as a potential cancer therapeutic agent. This is, I will walk along this number 6 and 7 for this presentation. Okay, again, this slide show on my right side show the causes of honey, the causes of the cancer, and the left side is the show the list of properties of the honey, which contains a high antioxidant. That's why honey is good a natural product against the cancer. So I will touch a little bit on research on honey. This is the research that was done in USN by our honey cluster. So this research is done during 2017, which is involved the in vivo study, which is involved in animal study that we give induce breast cancer in animal study. We induce breast cancer with the methyl nitrosourea, which is the agent that induces the breast cancer. So for this research, this is we give the honey 1 week before induce the breast cancer and followed for the 3 months for the treatment. So this result show that we divide to 4 groups, which is the group 1 is the negative control for honey, negative control, which is did not receive any honey either for preventions or therapeutic, which is the tumor progressions, tumor growth is the fastest in the group A. Why for the group 2, 3, and 4, we give the different doses of honey, which give the result that the dose for the group D, which is 2.0 per kilogram the progressions of the tumor is slow in the group D. So this research conclude that honey is better for the prevention and also for the therapeutic. So it does not mean that taking honey alone is not enough to prevent the cancer, because we also need to modify our lifestyle to prevent the cancer. Besides using the honey, we need to have a lifestyle modification, which is with no stress in our life and also get a good sleep. Besides that, we need to do the exercise daily, which is need to produce a sweat, and we need to reduce the low meat consumptions. And the most important one is our daily food, which is need to reduce or less eat the crab. Crab is, as we know, that C for the carbonated drink. We need to reduce the refined sugar, or we call it the white sugar. We need to reduce the artificial sweetener and all color, and also the processed food. But we need to increase in our daily activity is daily meals. We need to eat more food, which is fruits and vegetable, organic lean protein, omega, and also drink water. So, as a summary for this presentation, this is the cancer is increasing on towards the rise, but this our research showed that honey has been shown to have anti-cancer properties, and we should take honey daily is about 20 grams per BD. 20 grams is equal actually to 1 tablespoon as a natural anti-cancer, or we call it as a vaccine booster. So besides that, we also need to have a healthy lifestyle, which is we need to exercise daily, reduce the risk factor, reduce the sugar, and reduce the processed meat consumptions. It shows us that prevention is better than cure. So we do not smoke, don't get obese, no stress, good sleep, and be physically active. Inshallah, we can reduce the cancer. This is more towards that we highlight that honey is one of the natural products that give anti-cancer effects and also for the preventions. Before I before I end of my presentations, I, on behalf of USM, we are so honored and so thankful to the WIHU and also the Bible University for the very, very great hospitality. Actually, our USM delegation, we go to Turkey on the September to October this year, September 24th, and we send our elective student there to Bible and also to the WIHU, and we are so honored and thank you to the WIHU for the very, very great hospitality. So this is some pictures that our USN delegation to the Turkey last month. Okay,
thank you.
Before end of my presentations, to show us our very honor and also thank you to WIHU and Bible University, I will end my presentation with the short video that we have that experience that we have get and very great hospitality during the Turkey visit. Is it okay for me to share this video?
Thank you, Ms. Omar, because our time is very limited. Okay. Thank you very much.
This is only 1 minute video. I just
yes. Yeah, okay. You visited Bolu, I think. You were very happy, your friends very happy in Bolu. Thank you very much. Okay, hocam siz diyelim lütfen.
And time, thank you very much for presentation. Evet, sırada diğer önleyici tedbirler konusunda yine thank you Ahmet Damitri.
Thank you, Ahmed Damitri from San Malaysia University. He will talk about other preventive measures. Is he here? Is he online?
Ahmed? Assalamualaikum.
Welcome. Thank you Ahmet.
So, okay, thank you
Can you
for
hear
me.
me?
Sesi. Mikrofon açık, tamam.
Hello. Do you hear me?
Yeah, I can hear you.
Yes.
But actually, I have a problem with my internet connection.
Okay.
So I have asked Mr. Furqan to play my video that I have sent to him. So could you please, Mr. Furqan, play my video for my presentation?
Yeah, there are only 15 minutes. If you prepare, is your presentation or video? Okay. Finished. Hello. Arkadaşlar, problem var mı? Geçelim mi? Başladık. Hello, Mr. Ahmed.
Yeah, I have shared my screen.
Yes.
Can you see my screen?
Yes, we are hearing you. Please begin us. Okay. Please presentation. Yes, your subject is the prevention of cancer. Okay.
Okay. So can you share my? Can you see my screen?
Yeah. Please.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And very actually it's in night, but very soon in Turkey. So I'm going to present my topics on the prevention of cancer. So the top of my presentation today is about the concept of Muslim practice in cancer prevention. The second one is about the food as medicine. The third one is about the healthy lifestyle. And the last one is about the enhancing the population-based personalized screening program. So as an introduction, as cancer is any of a wide range of illness that characterized by the growth of aberrant cells with the capacity to invade and damage healthy bodily tissue while divided uncontrollably. So the cancer frequently has the capacity to expand throughout the body, and cancer is the biggest global killer. So screening and prevention, both that can reduce the mortality from many cancers. The screening aims is to detect the abnormalities before you are clinically apparent, allowing for the intervention either before cancer develops or at any early stage when the treatment is most often effective. So the prevention strategies focus on modifying environmental and lifestyle risk factors that promote cancer. Despite a robust knowledge of what factors decrease cancer risk, the implementation of cancer prevention lag. So what is the prevention? In Islam, we have said that al-wiqayatu khairu min al-ilaj. So according to the religion of Islam, Muslims are strongly encouraged to seek treatment and care but still some of our Muslims use cultural and religious supplement to help them treat their cancer and relieve their symptoms. In example, black seed and special herbs are one of the example. So the definition of prevention is about the act of stopping something from happening. So according to the widely reported statistic, 80 to 90% of all malignancy have a link to environmental and lifestyle factors, and some of these causes may be avoided. The most striking example is lung cancer, where 80% of cases are directly attributed to smoking. The worldwide tobacco smoking and chewing is responsible for 2.5 million deaths yearly. So the majority of malignancy in people can be avoided, with several cancer research facilities estimating that between 80 to 90% can be avoided. So in terms of infection, viral and parasitic, and the diet, and the number of the other elements that are entirely or partially influenced by a person's behavior are example of extrinsic factor in addition to the chemical. The rate of occurrence of various cancer can be significantly impacted by Islamic teaching that regulate human behavior and personal lifestyle. The numerous malignancies are linked to practices that Islam forbids, such as chewing and the smoking tobacco, drinking alcohol, being gay or promiscuous, and excessive sun exposure. At least among the 1 billion Muslims adherent to this principle will reduce the prevalence of several cancer and stop the pandemic from expanding. So the American Institute for Cancer Research has recommended 10 suggestions to prevent the cancer. So the first one is about be healthy weight, be physically active, and so on. Now we come to the food as medicine. Actually, the food as medicine is a concept of using food as medicine is based on the understanding that nutrition and food play significant roles in illness management and prevention. Actually, there are no single definition of the food as medicine concept, but it generally refers to prioritizing and food and diet in individual health plan with the goal of either preventing, reducing symptoms, or reversing the disease state. The emphasis is on consuming more whole, minimally processed plant-based food and consuming fewer highly processed food that are high in added sugar, oil, and salt. So for those people who believe that food can act as medicine are particularly interested in food that advocate claim have medical properties, frequently because they are said to contain high level of specific macronutrient and or biomolecule that also known as a functional food. So they are including a variety of herbs and spices, legumes, nuts and seed, whole grain and fruit and vegetable. So the food as medicine approach to health management challenges the construct of the conventional medicine, which relies primarily on technological medical advancement to manage health and disease with pharmaceutical drug. So you are what you eat, so you can make a choice whether you want to be healthy or you want to be unhealthy. So that make your decision. So for instance, increase of dietary of actually in our food they contain a lot of nutrition. Example, dietary minerals, antioxidant, allium, polyphenol, carotenoid, vitamin, and protein. So for instance, that an increase of dietary fiber support to lower the blood glucose levels in person with diabetes or diabetes, which reducing the occurrence of the nerve and blood vessel damage that is associated with the high blood sugar level as well as anti-cancer properties. So for the whole food that we consume every day that can lead to the obesity, then the obesity can lead to the cancer. Okay, so how actually the obesity can lead to the cancer? So first of all, in our cell that contain adipocyte. So adipocyte will secrete the estrogen that during the menopause. So the estrogen made by the fat cell can make the cell multiply faster in the breast and also womb, increasing the risk of a cancer. In terms of insulin and growth factor, excess fat can cause level of insulin and other growth factor to rise, which can also tell cells to divide more rapidly and increase the proliferation of the cells. And then the macrophage can cause the inflammation. So cells in fat that called the macrophages release chemical that we call a cytokine, encouraging cells to divide, including the cancer cells. The next one is about the healthy lifestyle. So the healthy lifestyle or behavior, which improving our health and lowering our risk of many cancer as well as heart disease, stroke, diabetes, and osteoporosis. And even small changes can have a big impact. So the tip for the healthy lifestyle, first one is about the maintain of the healthy weight. So the keeping the weight in check can be hard, but it has amazing effect in our body, including lowering the risk of 13 different cancer. And it's important to fit at least 30 minutes of activity every day, but more is even better, but any amount is better than none. The tobacco causes many types of the cancer along with the other serious problem. So stay tobacco free if you smoke or use smokeless tobacco like chewing tobacco, stuff or sinners. Quitting is one of the best things that you can do for your health. But yes, it's hard, but you can do it. Next, the basic of healthy eating are pretty simple. Focus on fruit, vegetable, whole grain, and keep the red meat and processed meat to a minimum. But it's also important to cut back on the bad fat, saturated and the trans fat, and choose a healthy fat such as polyunsaturated and monounsaturated fat more often. And then the drinking alcohol can increase the chances of developing 6 different types of cancer, and just half to 1 drink a day can increase the risk of the breast and colon cancer. While moderate drinking may be good for the heart in adult, but zero alcohol is the healthiest choice overall. While for the warm sun that can feel great, but the too much exposure, it can lead to the skin cancer, including melanoma. And the tanning beds can be just a harmful skin damage that starts early in the childhood. So it's especially important to protect the children. The next one is about the sexual transmitted infection like the human papillomavirus HPV, the hepatitis and HIV that can cause a number of different cancer. Protecting against this infection can lower the risk. So there are a number of the important screening tests that can help protect against cancer. Some of these tests find cancer early when it becomes more treatable, while others can actually help keep cancer from developing in the first place. That can sugar cause cancer? So the answer is no, because there is a link sugar, obesity, and cancer. So this sugar actually can contribute to the obesity, and obesity can make our body to produce a tumor that can cause the cancer. So and also the sugar sweetened with the cancer and also the obesity. But but the finding is found that no association or any major cancer. Okay, the next one is about the chicken. So actually, they have been reported that chicken is not a healthy choice right now, because they found that some of the chicken to the prostate cancer, breast cancer, urinary tract infection, and also the foodborne illness. The last point is about the enhancing of the screening-based population program. So it is possible to increase screening program coverage by implementing new, less invasive, more acceptable tests, specifying screening through a correlation with amnestic, clinical, radiological, and genomic data, which refer to the population-based personalized cancer screening, and utilizing the cutting-edge information and communication technologies like smartphone application or customized text message so-called as a screening 2.0. So in order for eligible pupils to be able to communicate their uncertainties and their perceived psychosocial hazards, advocacy and advice from doctor may also be important. However, the new screening initiative should only be launched following a true evaluation of health technology within the context of evidence-based medicine and the strengthening of the organized screening program and the limitation of opportunistic of the spontaneous program. So from the internet, I found one device that they call as Braster. So Braster is a mobile device like ultrasound, but the Braster is a medical device that monitor the distribution of temperature in the breast and can record areas of higher temperature which may indicate of the malignant changes. So the advantage of Braster system include the ability to perform a reliable monthly self-examination and to receive result without leaving one's home. So the Braster actually is very suitable to do the screening in rural area. So as a conclusion, prevention, particularly in primary prevention, is an effective way of addressing the challenging issue of cancer, since between a third and half of cancer could be prevented on the
Mr. Ahmed,
basis of our current knowledge of the risk factor.
Mr. Ahmed, can you hear us?
And not reliant on the socioeconomic position, they are also cost-effective, do not just affect high-risk individual, but the
Mr. Ahmed,
type of
hello,
population.
Hello.
In terms of epidemiology and expenses, the development of more advanced imaging and diagnosis actively selectively target tumor cell is resulting in more expensive treatment that may only be accessible to a small number of patients. And the final one is regulatory action generation by educating and empowering people, encouraging healthy habits, and promoting self-care that can start a positive cycle. So with that, I end my presentation. Thank you very much.
Thank you, Mr. Ahmed. Thank you very much for your presentation. Okay. Yeah, and here, good evening. Perhaps your country, good morning. Okay. Ma selam. Selamünaleyküm. Arkadaşlar tamam.
Evet.
Thank you, thank you.
Şey okuyalım şunu. Kanserden.
Evet hocam, son.
Evet. Ben korunmada sağlık okur yazarlığı konusunu Seçil Özkan
Gelmedi değil mi? Yok.
herhalde
Yok, Seçil Hanım
gelmedi mi? Evet. Peki.
Ha, burada mı? Ha, tamam.
No, she's here. Seçil Özkan is here. You have 15 minutes. Many things have already been mentioned before my presentation. I'm coming from Gazi University, and I am working on health literacy. It is my specific field of expertise. I've been working on this. What I will talk about is, we already experienced the COVID-19 pandemic, and hopefully it is over. But what I'm going to talk about is a silent pandemic. This will be a problem for us in healthcare sectors and I believe healthcare professionals will always experience this problem. Health literacy levels of the society, how much of those things that are said are understood is an issue, and it is one of the main factors which is affecting the healthcare. This is on the media. There was an amniotic band, and there is a question mark over here. An amniotic band is is a medical thing for thematical term, but they put on the TV as a news which stated that a band is forgotten in the belly of a patient. So it was just a misunderstanding. It is because of the health illiteracy, and these are affecting all our health. And cancer protection, prevention strategies will be discussed, and I will talk about health literacy, what can we do about health literacy, and what are we doing about it, will be the main topics for my presentations. You know, health is wellness in terms of physical, emotional, spiritual, and social. So we should be healthy in terms of social, physical, and spiritual aspects. And when we look at the reasons of dying in Turkey, the cancers are ranking the second. And when we look at the cancer types, lung, breast, and colorectal are the first three. And when we look at the main factors which are affecting health, 60% is affected by lifestyle, and 15% is hereditary conditions, and 7% is climatic conditions, and social conditions are also affecting this. In the rainbow model, we can see that there you can see the main determinants of health, and other lifestyle factors are quite effective. And in the previous presentation, we talked about this obesity, alcohol use, and nutrition. These are all important life factors which are quite important, which are quite significant. And probably in Turkey we will have another survey about this non-communicable diseases. This was conducted in 2017, and our figures in Turkey is not quite well. I will not be able to read them one by one. Probably you will put it in the Congress page. And cancer screening programs and participation to cancer screening programs are also important. At the end of this study, we have the participation to cancer screening programs, and in cervical smear and mammography, there is a 50% increase, and in occult bloods and guides in stool is also checked. And for protecting our health, we can talk about four main strategies. Main protection and primordial protection. We are not just talking about persons' risk factors. We focus on them to live healthily. We try to provide possibilities to give him or her a healthy life. And in the primary protection, we have risk factors, and we have specific studies. And we try to decrease the risk factors. We want them to be active, physically active, and we work in cooperation with the other sectors, and healthcare sector is going before.
Early diagnosis and treatment are important strategies in cancer programs. In Turkey, we have a program, as in the other parts of the world. We need to increase the involvement in these programs, and in order to prevent the patient's death, we include them in these protection strategies. Basic protection strategies are less costly. In third stage, we have more costly strategies. So based on the cost, we need to identify our strategies, and we need to include other sectors in our protection strategies. And there's a multi-stakeholder strategy in healthcare industry, and this is important in including all parts of the society. Healthcare literacy includes individuals' access to health information and their interpretation of such information, and it is important for many aspects. First of all, they can sense the coming risks and they can react to it. For instance, if does an individual know what kind of risk factors the individual carries against the different types of cancers, and then the individual should exhibit a behavior to prevent this, such as involvement in a protection program. And in the next stage, the individual should have the understanding of how effective this behavior is. Is the person going to apply for a cancer protection program? Does the person have access to cancer centers? And does the person have enough awareness for better nutrition or any behavior that will protect the individual against the cancer? Of course, there's some false information spreading, but the individual may be afraid if this reactive behavior would help him, her, or not. So the healthcare literacy is correlated with this behavior of the individual. As I said, the healthcare literacy includes reaching information, analyzing, and implementing this information. Of course, there are other factors affecting the healthcare literacy, individual characteristics, socioeconomic situation, and of course, the approach of the healthcare personnel influences the healthcare literacy. In the U.S., only 12% of the adult population has healthcare literacy. In Europe, 46% of the population was identified to have insufficient healthcare literacy, and in 2019 this research was repeated and they could decrease the healthcare literacy. They could increase the insufficient healthcare literacy by half. And in Turkey, 68% of individuals do not have health literacy and they cannot protect themselves. In Turkey, there was a research about breast cancer and screening attitudes, and there's a correlation between women seeking screening options and their health literacy. There's another research in Taiwan, and there's a correlation between their participation in screening programs and their health literacy. Another research from Iran, it was identified that women's interest in participation of screenings was relevant with their health literacy. And lastly, a 2022 research reported that the participation of individuals in cancer screening programs was correlated with their health literacy. And here's a research that we did. Cancer awareness score is relevant with their health literacy score. So where do they get the information? Informational brochures and information desks. There are different types of information sources. Health literacy is low in Turkey, as in the rest of the world. As the healthcare personnel or those working in the field, we must first identify our insufficiencies and then work towards improving them. So, what should healthcare personnel do? During examination, healthcare personnel may identify cancer-relevant symptoms, and they must have the literacy and the communication between the health personnel and the patients is important here. It was also included in the 2019-2023 strategic plan of the healthcare ministry. And I know that the health ministry also published a health literacy action plan, and some countries in Europe have similar action plans, and Muslim countries should be supported to create their own action plans for health literacy. We must support them. And as the first level physicians are very effective in identification of illnesses and increasing health literacy, we must provide the doctors with enough material. We created a project on health literacy in adults, and this one is a continuing project, and it can be enhanced with cooperation. And in this project, we focused on defining the health literacy and how we can educate doctors so they can contribute to increasing the health literacy. And we also have a Turkish Journal of Health Literacy, and I would like to ask all doctors and academicians to contribute to our efforts. So here is my summary. Health literacy level is scientifically proved to have an impact in cancer protection. If we can increase the health literacy level of the society, we can protect cancer, and we must work in a multi-stakeholder approach. I will wrap up my presentation. For protection, we must increase health literacy. Thank you. Thank you, Professor Seçil Özkan, for your presentation. Thank you. The last speaker of this session is going to talk about the role of dysbiosis in cancer. Dr. Susilironi, Üniversitas Islam Sultan Agung, Semarang, from the Department of Pathology, Anatomy of Faculty Medicine. Welcome.
Prof. Ahmed, Prof. Ahmed, and also the chairman of the committee. Please allow me to talk about the role of dysbiosis in cancer. And I will start with the outline of my presentation. Yeah?
Here, yeah. This way.
Okay. So, this is the outline of my presentation. I will start with introduction and then defining dysbiosis and factors that influence microbiome and cancer-promoting effect of dysbiosis, and the last one is the role of dietary in carcinogenesis. Okay, let's start with the introduction. As we know, cancer is a complex disease which involves genomic and physiological alteration that arise regularly in the cancerous tissue, and a growing body evidence has found that human being is composed not only by his own genome but also microbiome. Microbiome plays an important role in the maintaining the normal physiology of the human body, and the microbial imbalance, especially in the gut, called gut dysbiosis, is now supposed as one of the entrants to cancer, and gut dysbiosis could increase cancer risk. Here is the new concept of health that state that there are three main factors influence our health. They are brain, and then gut and microbiota. The microbiota control our health and our disease, including the composition, proportion, the condition of eubiosis or dysbiosis, and also the psychobiotic. The psychobiotic, including three kind of behavior of our microbiome. They are symbiotic, or amphibion, and also pathobion, or we already know it as pathogen. So what is dysbiosis? Healthy state is defined by homeostasis condition, and disease is loss of homeostasis, and the root of the loss of homeostasis is dysbiosis. There are three kinds of dysbiosis. They are pathobion, expansion, and then loss of commensal and also reduced diversity. There are a lot of factors influence human microbiome. We can see here that genetic, our environment consists of micro and macro environment, and then diet, lifestyle, hormone, and industry, pollution of industrial product, and then also using of preservative, using addictive food. It will influence our microbiome. Here is the detailed factor that can influence our microbiota homeostasis. They are including probiotic, prebiotic, vegetarian and non-vegetarian diet, and also infant diet, because the crucial factor that will lead to homeostasis or eubiosis is in the critical period of infant. And then using of pharmaceutical product, just like antibiotic, non-antibiotic drug, including PPI, and then infection, viral and bacterial infection or enteropathogenic infection, AIDS, life stage, infancy and old age. It will decrease our diversity of microbiome. And then lifestyle and social factors, delivery mode, smoking and drinking alcohol, social interaction with other people and also our environment, and then our pets, production of several molecular signals like antimicrobial peptides, and then mucus, and the secretion of immunoglobulin A, and also microRNA and our immune system, including innate and adaptive immune genes. And as we know, as also mentioned by the previous speakers, food, nutrition, obesity, and physical activity will also influence our microbiome and also our cells. It will influence DNA repair, carcinogen metabolism, proliferation of our cell, hormonal regulation, differentiation, and then inflammation and immunity, apoptosis, and also cell cycle. So here is the detailed mechanism of how dysbiosis can promote cancer. The biggest ecosystem is in the gut. So why Hippocrates say that all disease start from the gut? But it doesn't mean that only gut dysbiosis will lead to cancer, but also in another side of our anatomical body, including oral dysbiosis and then endometrial dysbiosis and skin dysbiosis maybe. But the main factor is gut dysbiosis. It is known that condition of eubiosis in the gut will lead to tumor suppressive activities because it will lead to carcinogen binding, reduction of secondary bile acids, and then maintenance of gut mucous barrier function, increased production of SGVAs, production of anti-inflammatory cytokine, for example, interleukin 10. And the dysbiosis of the gut or gut dysbiosis will lead to cancer progression because of production of radical oxygen species and also nitrogen oxygen species. It will lead to DNA damage, stimulation of pro-inflammatory cytokine synthesis, including interleukin 1, interleukin 6, and also TNF-alpha. And it will lead to leaky gut or gut increase of gut permeability. Sorry. So this is the schematic illustration of how eubiosis and dysbiosis will alter our system, where community homeostasis of our gut ecosystem will lead to decreased inflammation, decreased oxidative stress, balanced gut microbiota, and then production of mucin layer, and it will lead to protection of our epithelial layer, and also healthy enterocyte and intact tight junction. And dysbiosis will lead to host inflammation, and it will activate keystone pathogen, and then bacterial recruiting, and also bacterial driver, not only bacterial, but also bacteriophage or virus. And then it will lead to leaky gut and bacterial translocation. And it will promote alteration in physiologic response, including increasing of inflammation, increasing of stress oxidation, oxidative stress, imbalance of gut microbiota, degraded of mucin layer, inflamed enterocyte, and loss of tight junction. And it will lead to alteration in the metabolic and molecular response, where in the eubiosis condition, characterized by the increase of antioxidant, increase of indole, increase of butyrate, increase of ursodeoxylic acid, they are all is metabolite, bacterial metabolites, and then decrease of NF-kappa B, and also interleukin 17. And when there are dysbiosis, the alteration of metabolic and molecular response is increase of NF-kappa B and increase of NOS, also a lot of parameter of inflammatory cytokine and also neuropeptide. And it will lead to alteration in the cellular response, where in the condition of eubiosis, there will be increased apoptosis and increased cell proliferation, but in the dysbiosis condition, it will lead to decreased apoptosis, increased cell proliferation, increased inflammatory microenvironment response, just like increase of TLR and NLR activity, increase of activity of or differentiation of M1 macrophenotype, and it will lead to decrease of DNA stability, increase of a lot of parameter of proliferation cell, including ERK signaling and also VNT signaling. And it will lead to cancer risk. In general, dysbiosis and also single pathogen is known to be the root of the carcinogenesis. Together with environmental triggers and also dietary triggers, it will lead to microbial infection and exposure to chemical and radiation. It will lead to free radicals, oxygen and nitrogens, and it will promote the condition of oxidative stress, and it will increase bacterial toxin, and increasing bacterial toxin will lead to increased permeability of the gut, and it promote chronic inflammation and DNA damage, and then it will lead to microbial translocation where it will induce hyperproliferation and also DNA damage, and there is carcinogenesis. Here is some example of microbes involved in the progression of various types of human cancer. For single pathogen that we already know, including Helicobacter pylori in cancer type mild lymphoma, and so on. And here is multiple bacteria involved in colorectal carcinogenesis. There are a lot of bacteria here, and the psychobiosis is pathobion. And the last but not the least, the topic will be role of dietary on carcinogenesis. I won't explain on detail because the previous speaker has explained a lot about it. In history, we know that in 1971, Dennis P. Burkitt analyzed the relation between bowel cancer frequency and fiber intake by different population, and highlighting notable difference between Western diet, where bowel cancer is more prevalent than least development communities, and it is stressed out the importance of fiber and also the bed of carbohydrate simplex, that we know that fiber affected intestinal transit time, stool consistency, and bacterial microbiota related to cancer incidence. And we know that Western diet is rich of high protein and fat and least fiber, and it may induce carcinogenesis through microbial activity in the intestine. Red meat consumption also modulates the microenvironment in the intestinal region. I will explain in this in the next slide. Here is the detailed mechanism. The dysbiosis will increase risk of cancer by direct and indirect mechanism, by by the attachment of the microbes antigen molecular pattern on the PRRS, or here is NLRS, and it will lead to increasing of inflammation, and it will lead to pro-inflammatory mechanism, and it makes the microenvironment more pro-inflammation. And then when we consume red meat, it will lead to increase of genotoxin, including colibactin and CDT produced, and it will lead to increase of stress oxidative in the microenvironment, and the growing of pathogen or pathobion, and it will lead to increasing of bacterial product like hydrogen sulfide and also ROS production, and it promotes the development of cancer. And then when we eat a lot of carbohydrate and also refined sugar especially, it will lead to the production of acetaldehyde from ethanol, and it is also promote the condition of cancer development. Here is the role of dietary intervention and probiotic. And I won't explain on detail, but I will stress
Excuse me, please.
Okay. It's already explained by the previous speaker, and I will skip it. Here is the role of the prebiotic, and then natural source of prebiotic here, including fruit, vegetables, and then there are also artificial prebiotic, and there are metabolic derived from microbiota and its role in cancer. We know that there are SCVA, including butyrate, and then polyamine metabolite, and the conclusion and future direction. Dysbiosis is principally relevant to cancer biology in view of alteration of metabolism and inflammation. So, a result of detrimental metabolite and antigen produced by pathogenic microbial population are recognized as hallmark of cancer. The microbiome and its association with cancer in human is important worth investigation, as there are variety of factors, especially diet, that affect or change the microbiome composition over time, and the microbiome could be targeted or modified in a manner to improve cancer therapeutics. And keeping the above factor in mind, one may conclude that a change in diet could bring significant change in microbial composition. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much for presentation. Now, şimdi oturumu ara vermeden tekrar.
Now we have a break, but we won't have the break. We will continue our session. So in our fourth session, Ramiz Aliyev and the other moderator will be joining us online. Mr. Orhan Çömlek is here, I think. Orhan Çömlek is not here. I would like to invite Mr. Ahmet Tepe for moderation. We also had the question and answer session, but we will skip that one too. I think the presentation was clear. I personally learned so much from this presentation. Thank you for your patience. Thank you. First speaker, current developments in cancer diagnosis, Dr. Babikir Ismail Ahmed.
He will join online. Welcome. You can start. You can start. The floor is yours.
Now?
Yes, please.
Kulak. Yes. Babikir hocam sözü size bıraktık ama. Ya, dondu mu?
The floor is yours. The floor is yours, sir. Then we can continue with the next one, maybe.
أنت جاهز؟ أستاذي أستاذ الكريم
السلام عليكم ورحمة الله وبركاته.
وعليكم السلام.
Yes, thank you very much for inviting me to talk in this important conference, WeWho conference. And I would say hello to all my brothers and sisters in WeWho. I couldn't attend in person, but I hope that I could deliver this message to you about current developments in cancer diagnosis. And I think you have been told about the magnitude of the issue of cancer since early morning. Can I have the next slide, please? Yeah. So I'm not going to repeat for you all what you have learned today about the cancer and incidence of cancer and cancer incidence rate. I'm going to skip this slide, so if you could get me the next slide, please. So if we want to know about the magnitude of the problem, as you have heard, in the United States in its own, there is about 1,800,006 cases every year of cancer. Next, please. And in Europe, the European continent population is about 25% of the whole world. Sorry, it's 9%, but the burden of the cancer is 25%. And that is because of the aging population. People in Europe live longer than the developing countries. Although they have good system for detecting cancer and good protocols for managing cancer,
but still the incidence of cancer is very high due to longevity of living. People live longer, and then also there is a lot of contamination and cancer carcinogens in the environment, in the food, preservative, smoking, HPV infection, etc. All these reasons together make the burden of cancer is about quarter of the whole world. Next, please. And this is the same thing. So next, please. Again, next. If we come to my continent, to Africa, the incidence of cancer is almost half of that is in the United States, about 752,000 cancers per year. And the leading cancers are breast, which is about 15%, which is cancer, and then colorectal. So the pattern itself is different from that is seen in the developing world. You could see here Kaposi sarcoma, which is about 4% of cancers in Africa, mainly found in areas like Africa. There is also the Hodgkin lymphoma as well is prevalent because, as you know, this time virus and all these viral infections can also be a reason for cancers. Next, please. In Asia constitutes about 60% of the world population and half the global burden of cancer. So it is a fair share for cancer. Currently, it is 6.1 million. Currently, it's not that so current. It's in 2008, and it is projected in 2030, i.e. in 8 years from now, it's going to be 10.6 millions. And among the reasons of increasing cancer in Asia is growing population. As you know, in Asia, there is expansion. There is always one continent, 60%, almost 2/3 of population. And also the lifestyle is changing with a lot of changes in socio-economic status, like in India, in China, and even in Turkey, for instance, there is increase of income and there is changing lifestyle. So this is reflected in increasing incidence of cancer. Next, please. So as you could see, and as you have heard also earlier from my previous colleagues, that cancer is a global issue, is a global problem. And in the developed world, the mortality is decreasing. And that is because of the high technology in detection, early detection of cancer, and good health system. And also they have a standardized form of managing the cancer through protocols and guidelines that they follow them strictly. While the incidence of cancer is increasing in developing countries due to increased aging, as I have said, and changing of the lifestyles. And we want to also improve, my aim here of this presentation is to try to convince developing countries to follow standardized protocols in diagnosing and in managing the cancer. Next, please. So my main talk is about the role of pathology and laboratory medicine in reducing cancer and in managing cancer. Good pathology service is very essential and integral part of cancer management. The two arms that help a lot in management of cancer is pathology and radiology or imaging. They play a very important role in detection of cancer and in early management of cancer. And pathology now is not only helping in diagnosis. There is now more recent role of pathology in prognosis and in management of cancer. So when we combine pathology with molecular testing and genetics, the pathology can play a vital role in preventing cancer through screening family members who had cancer, that by geneticists, and checking and screening for abnormal genes like the BRCA genes and the POL genes and the HRD, etc., which can be present in some certain families and affect family members. So the role of pathology, genetics, molecular biology combined will help to reduce this form of cancers. Next, please. So by pathology, conventionally, we mean histopathology and cytology. And the laboratory medicine will include chemical pathology, hematology, and microbiology. So I will start the role of histopathology and cytology at the beginning, and then we'll expand to the role of the other laboratory divisions. So in histopathology, the diagnosis, histopathological or tissue diagnosis is a prerequisite for oncotherapy. Still now, oncologists, they insist that they will not give any treatment, oncological treatment, without having a tissue diagnosis. For two reasons: because the oncology treatment is very expensive, and also because the treatment on the patient is very comprehensive and put a lot of pressure and change lifestyle and may compromise even the well-being of the patient. So they will not provide any treatment without having a histopathology or a cytopathology report suggesting that there is cancer. At least this is the practice which is done in UK and in wide areas of the world. I would be happy to listen if there are different practices somewhere else. And because of this importance of pathology and histopathology, now there is approaches to make a standardized form of reporting. The two well-known forms of cancer reporting protocols are the CAP protocol, which is the College of American Pathologists protocols, and also the minimum data sets of the Royal College of Pathologists of the UK. These are now internationally accepted as two comprehensive standardized protocols for reporting histopathology and cytopathology. And these two protocols, they have list of data, and the list of data is divided into two groups: core data and non-core data. The core data are the very important and essential data that each report should have. The non-core data are the data that can vary from institute to institute, from practice, local practice to local practice, from hospital to hospital. So there is a bit of a degree of allowance for not to include the non-core data. But the core data are very important and they should be included in all protocols of the individual cancers. Next, please. So I will give you an example of CAP, which is the College of American Pathologists, synoptic reporting. Just an overview. This is an example of a form that contains essential information on the in one line. And for instance, invasive cancer of the breast, like biopsy, for instance, then you have to fill these spaces. The procedure, you have to put what was the procedure, like needle biopsy, for instance, fine needle aspiration, or other biopsy, excision or section, etc. And the measurement, you provide the largest diameter first, then you give the other 3 dimensions. So the most important one, the core one, is the largest diameter, because also you have to give the histologic type of the cancer. And for instance, for breast carcinoma, and rely on the Nottingham histopathology score. Next, please. So in breast biopsy, the Nottingham histopathology score depends on 3 elements. Tubular differentiation is the first element, then nuclear pleomorphism is the second element, and the third element is mitotic rate. Each of these 3 elements is graded according to either mild, moderate, or severe, and they will give a score for each. The mild
Ismail,
is 1, moderate
sorry,
2, and severe is 3.
I interrupted
Yes,
your speech. Excuse me. Please, conclusion and summary.
Okay, could we go to the next, please?
Okay, yeah, because our time is very limited. Okay.
Just in this page here, there are some molecular immunohistochemistry like ER, PR, HER2, and the Ki67. We include this in all breast cancer cases. Next, please. If all these are just immunohistochemistry showing the 3 ER, PR, and HER2. And there is also HER2 by dish on the left side. Next, please. If these are negative, they will call it triple negative. We will go for PD-L1 testing, and that is immunotherapy. The next role is cytopathology. Cytopathology, as you know, could be beneficial in screening, like cervical screening program, and also for breast screening, and for diagnostic purposes like lymph nodes and bumps and lumps on the skin. Next, please. Molecular biology, like sequence. Can I have the next slide, please?
Yeah, excuse me. Thank you very much. Your speech, presentation. Okay, because there are some people they are waiting your speech. Thank you very much. Thanks a lot. Perhaps you will send your presentation us.
No problem. Thank you.
We will prepare
All the best.
and we will print it. Okay. Thank you. Bye bye.
Thank you very much. Bye.
Babir gibi Teşekkür ediyoruz bu güzel sunumu için. Sırada ikinci oturum. Ankara Onkoloji Eğitim Araştırma'dan Profesör Doktor Gülün Uçbak hocam.
Okay.
Kanser tarama yöntemi, nükleer tıpta güncel gelişmeler. Buyurun hocam.
Herkese merhaba Sayın Başkan. Değerli
Merhaba hocam. Buyurun hocam. Söz sizde.
The floor is yours.
Hocam sesim geliyor mu? Beni duyabiliyor musunuz?
Tamam.
Hello everyone. I would like to congratulate everyone who has contributed to the meeting. We have already exceeded the time and I will continue with the presentation immediately. You can see that nuclear medicine is really important in the cancer diagnosis, and it is a modern, relatively modern system or branch. It is about the organ functions, it measures organ functions, and it detects the changes, cellular and molecular changes. And we also have other gamma probe applications. We use UCG, ultrasonography, and we also use radionuclide treatments and theranostic applications, and we also provide clinical services. You can see the current developments in the nuclear medicine. We can talk about radiopharmaceuticals, or we can also talk about some technological developments. When we are using scintigraphy or PET, and in terms of technological developments, we can now talk about SPECT and SPECT CTs. And we started with PET, and we continue with PET CT and PET MRI. And recently we are using gamma probes. And if you are going to evaluate these combined SPECT CT systems, then my anatomic localization and attenuation correction is increasing the diagnostic correctness. And their sensitivity is really high. It is about 90%. I will talk about real cases. You can see the scintigraphy of prostate cancer patient. You can see the SPECT CT study. There is a suspicious involvement, and in SPECT CT you can see in two focal areas we have oligometastatic prostate cancer, oligometastatic disease, and we plan the treatment. And here we have another prostate cancer patient. There are involvements, various involvements, as you can see here, and especially on vertebrae. And with metastatic disease, you can see the degenerative or constructive changes. And this is a parathyroid cancer patient, and we have some structural anatomic lesions, and we have the involvements here. In cranium, in addition to this, in cranium and in lower extremities, we have brain tumors. You can see the involvements, and we have a neuroblastoma patient. We have an MIBG study for this patient, and in the screening we see a suspicious focal involvement. And this is a thyroid cancer patient, and this is after the treatment. As you can see in this region, there are some involvements, and these are we don't know. We need to understand anatomically their location, and we had a SPECT CT study, and you can see the mediastinal lymph nodes here, and we have the metastatic involvements in lung, and even before we see the anatomic changes. And in COVID, it was important, especially for pulmonary emboli, because we were not able to ventilate these patients for a long time. As you can see, we had a perfusion SPECT-CT study during the COVID-19 for a lung, and the patient was 40-year-old and operated for breast cancer, and the D-dimer is followed by 790, and we were able to use these new technologies. So I want to talk about the sentinel lymph node and lymphoscintigraphy. These are really important, especially for melanoma, for microscopic patients and lymph nodes or clinical negative lymph node metastasis. We can detect this. We don't know if there is any other more reliable methods, and it has reliability is about 95%. Accuracy is 95%. This patient is a breast cancer patient, and we do the injection, and to the axillary area there is a drainage and there is a focal involvement. And when we look at the SPECT-CT study, in addition to these lymph nodes, there are internal nodes and it is drained, and in the axillary there is lymph node metastasis, and we started chemotherapy immediately. I want to talk about ultrasonography and radio-guided occult lesion localization. I want to talk about role system. In other words, these methods are very frequently used recently, especially for thyroid cancer, for parathyroid adenoma. They are very frequently used, and we use a radioactive material, and we send this to the place which is not easy to reach, and we are able to understand, we were able to detect the occult lesion. We increase surgical success significantly, and the rate of surgical complications is decreased. You can see that there are markers. There's a lymph node here, and with a needle we have a wash test, and there is papillary carcinoma metastasis, and we mark this patient, and we take it out with gamma probe, and we have the papillary carcinoma in this patient. And in oncologic cases, one of the most important modalities is PET. I will talk about it in short sentences. I don't want to take your time. We have a pathologist in the previous presentation. This is about a molecular imaging. We are able to look at the metabolic speed of metabolic rate of growth rate of the tumor, and we can use PET for this. And there are different modalities. It can be combined with CT, or it can be combined with MRI. And these are hybrid systems, and the MRI is newly developed, and it is used very frequently. This is our own PET CT, and we check whether there is a malignancy in a suspicious mass. And when we look at SPECT-B CT, it is quite dense. We can see the involvement, and histopathology is visible. But here, in this patient, there is breast cancer, and you can see the bone scintigraphy. And when we look at that, we don't have very suspicious area. But let's look at here. Other than the bones, there is a lymph node, and in vertebrae there is some staging, and we sometimes miss out on them. And there you can see the response. There is the response to treatment. Hodgkin lymphoma patient, and you can see involvements of the lesions. And then on an interim evaluation, you can see there is a full metabolic response in all lesions. One of the most important development is about the radiotherapy planning under the guidance of PET. We look at we check the dosages, we adjust the dosage according to the metabolic area, and finally PET CT is really important, especially for the correct staging, accurate staging, correct treatment planning, and it changes the treatment possibilities, treatment approaches. Choline is used in addition to FDG. It is for hyperthyroid or brain tumors. It is used. This is one of our patients, and this patient had a parathyroid adenoma, suspicious adenoma, and you can see the PET screening, imaging, and we have a millimetric lesion, parathyroid adenoma. In addition to them, we have, in the last 5-6 years, we have the gallium-68. We are using gallium-68 for in those PET imaging devices. One of them is DOTA, and we are using this for neuroendocrine tumors, NETs, for their staging, restaging, and monitoring the response to the treatments and medullary thyroid cancer and aorta refractory DTK. And when we give targeted treatment for these receptors, we are using it for their selection. And you can see the duodenum grade 1. In duodenum, there is a neuroindicated tumor, and it looks quite specific. You can see the cellular involvement quite clearly, and gallium-68 is used here. And this is a staging patient again. Unfortunately, in liver we have metastasis, and you can see it is on the pancreas head. And in addition to this, gallium-68 is used for prostate-specific membrane antigen and PSMA. We use this in combination with gallium and the adenocarcinoma is expressed on the prostate. And this is used generally for aggressive metastatic and hormone-resistant prostate cancers. This causes high involvement in this kind of cancers. We use this for low PSA levels and for staging of prostate cancer with low, moderate and high risk, and for the response to treatment and restaging and radiotherapy planning. We can use it for these cases. This is another patient of prostate cancer, and when we look, you can see the lesions.
And there is a question about metastasis. When we look at the PSMA, there is no anatomic difference, but there is a bone metastasis, and here we can see lymph nodes with metastasis. And here we see a patient with a slight increase in PSA, and you can see that this patient received radiation therapy after this detection. In radiation therapy planning, PSMA is really important, and in the long term, I know that we can benefit from PSMA differences. And we know that it will make a contribution to radiation therapy. As I mentioned before, PET MR systems are not very common in the world, but there are some advantages because the radiation dose is lower than the other types, and this is important for pediatric patients. And the PET technology is very advanced, and there's a contrast in soft tissue in MR. There are disadvantages too. The detection duration is long, and it is very costly in comparison to other systems. But there's more research on this. As you can see here, a colon cancer patient operated, and here you can see millimetrical liver metastasis. And there's also the theranostic application. This is a combination of therapy and diagnostics. So what do we do here? We target the same molecules and we use the similar agents, but we can identify what cells we will treat, and it's an identification method. I will give you an example here. This is a dotatate therapy example. This is a metastatic tumor patient, and you can see here on this section. And here we use lutetium dotatate, and we see that in the end the metastatic focus areas are gone and the patient continues his life. Again, in prostate cancer patient with metastasis, we applied gamma-68 therapy, as you can see here in this example, which we often apply with patients over old ages, and we can see that the PSA levels are lower than before.
Geçen bir alan ki nükleer tıp, hücresel ve moleküler.
Cellular and molecular imaging methods are really changing, and hypoxia imaging, estrogen, testosterone receptors, and liposomes, and there are drug carrying systems. We will see examples of this in application very soon in the near future. As the other speakers mentioned, microenvironment of tumor is very important.
Toparlarsanız Sayın Hocam.
Bitirdim.
Tamam.
Okay, I will wrap it up. And we will continue our research with new nuclear agents. Thank you. Thank you. Thank you for your presentation. And our third speaker is from Radiology Department of Erciyes University, Professor Dr. Abdullatif Coşkun. He will talk about electrical fields in cancer diagnosis and treatment. Welcome, Mr. Professor. Thank you. I have to share my screen, I think. Can you see the screen? Distinguished participants, I will talk about a very exciting technology. I will keep my presentation short, just a few minutes. If you have any questions, you may ask, and I will be glad to answer your questions. First of all, I'm really sorry because I could not join you there. I have an influenza infection. Unfortunately, I'm not there with you, but thank you all. I would like to thank the organizing team. As a radiologist, I could maybe talk about tomography or MR systems, but today I would like to talk about a very important technology that I am working on, electrocapacitive cancer treatment, ECCT in short. This was developed by Dr. Toronto in 2010. When he discovered that his sister had breast cancer, he developed this new equipment, and she was not treated with any chemotherapy. And for many years, his sister has been surviving, and this technology is from Indonesia. And these data that I will present are from Dr. Varsito. The first research on electrovarsity technology was done in Ohio State University, and they were working on oil treatment. And in 2002, it was approved by FDA, so it could be used by other therapy methods. In 2005, 15, another treatment method was developed and approved by FDA. But Dr. Varsito came up with another idea. He thought that electrocapacity could be used statically. So he developed a new idea. I know it's late and I don't want to go into too much detail, but I can answer your questions and I can share documents with you if you request. As you know, cancerous cells show different mechanisms of multiplication in comparison to normal cells. And when the tumor cells multiply, they are treated with ECCT and TTF by destroying the electrical field. So they go into apoptosis and the tumor gets smaller. So this is the basic mechanism behind ECCT and TTF. The difference between ECCT and TTF is ECCT is a wearable technology. And the cancerous tissue is treated with this wearable ECCT technology based on the location of the tumor. It can be a jacket, it can be a hat. If it's a brain tumor, it becomes a hat. Or it can be a pants. If there's widespread metastasis, it can be a blanket. It is produced for the patient in a custom way. It can be manufactured in different shapes and forms. You can see the equipment by the InnoCure firm. And in trials, it was stuck to the skin for lung cancer or skin cancer. And ECCT, in comparison to TTF, is easier to use. It uses the impedance current system. This is a semi-electrostatic system. It goes through the layer of air, and TTF targets the solid organs, but cell destruction mechanisms are similar. Of course, the indications in patients are different in these systems. ECCT is possible to use in every organ, and TTF is a very expensive technology. The monthly cost is above $20,000, and it should be used for 16 hours a day. But ECCT is more accessible financially, and it takes less hours. There are many immuno research on this, but I will not go into detail because we don't have the time. And there's some research that was done on mice. The mice were treated with ECCT and the tumor has become smaller. You can see the animal tests here. I want to show you a few examples I want to show you examples. So 50-year-old patient, and there's metastasis. She has breast cancer. There's widespread metastasis. After 6 months of treatment, you can see that the metastasis has diminished. You can see the patient looks a lot better. Again, another 48-year-old female patient with breast cancer. After treatment for 1.5 years, you can see the metastasis to the bone has gone. Another example is 2-year-long treatment on the brain, and you can see the patient has clinically healed. In early diagnosis, electrocapacitive volumetric tomography is used, and what the doctor who developed this technology did is he made it a healthcare technology equipment. And when we see that the pathologic development of cancer cells can be treated with ECCT. Another patient who was subject to glial tumor in early childhood ages, only with ECCT, they could make the tumor retreat in the 5th year. This patient graduated from university. There's only one complication in the eye. Well, he was bedridden before, but he graduated from university in a healthy way. And this is a lung cancer patient diagnosed in 2014. But now when we look at the X-rays a few years later, the tumor has gone. So briefly, ECCT was a promising technology in treatment of cancer cells. And TTF is currently used in 800 centers in the world, and the stock market value is between 10 to 25 billion dollars. This is a chemotherapy, radiotherapy. After chemotherapy, radiotherapy, and drug therapy, this is the 4th leading treatment method in cancer patients. And it can be used against different implications. Of course, we can detect how the body reacts to the treatment. I can show you how we detect the healing. This is also a physiological imaging system, and this is similar to other imaging systems. It can be used on brain or another organ or the entire body. You can see the examples. Many patients came to the center, especially breast cancer, brain cancer patients can detect the tumors in a few seconds. Very advanced computers are used. In addition to tumors, this imaging device is also used in detection of schizophrenia or Alzheimer's disease. And in Turkey, there are 2 universities who are working on cell changes, and they are doing animal tests. And ECCT shows the changes in the brain, and as an alternative to MRI or tomography, this is a similar nuclear medicine equipment. You can see the examples of images here. Thank you for listening. If you have any questions, I would be glad to answer.
Çok sağ olun.
Thank you for your presentation. Thank you. Now, I would like to invite the last speaker from the Ankara Oncology Research Hospital, Mr. Haktan Başardam. He will talk about genetics in cancer. You have 15 minutes. I will talk about genetics in cancer, and I would like to summarize because we have little time. Oncogenetics is related with medicine, and it has components in epigenetics, transcriptomics, genomics, precision oncology, proteomics, and metabolomics, and structural variants, copy number variants, and methylaton patterns, single nucleotides variants are the components of this. This is a field developing very quickly. 10 years ago, these were implied for only a limited number of cancer types, and it was implied for skin, breast, lung, and colon cancers. In colon, KRAS systems were discussed. Now it has become a predictive and prognostically important, and it has helped us identify genomic differences. What kind of diagnostic methods do we use? FISH system. This is a molecular genomic method. And when we use nuclear probes, we can identify the changes with fluorescent probes. Real-time PCR tests are used in very different fields. We also use it in genetics. We use it to identify single spot changes, structural changes, and there's also third generation sequencing tests, and they make up for a majority of the tests that we use at this age. Although it is not routinely used, I believe that these third generation sequencing methods will be more often used in the future, and there's the optical genomic mapping, and this is used for leukemia and lymphoma, and they are very practical. They are promising methods. Let's look at the workflow. What do we do in genetics of cancer? There are different stages that we go through, and oncologists and medical experts are involved in different stages of this workflow. Interpretation of the changes we identified, and we cooperate with clinicians, and experts have to work together through all stages of this workflow. In implementation, there is an implication to identify the genomic changes. Here we have different stages where we analyze the data. First, we go through VCF interpretation, and then we go through SOP classification challenges, and lastly, using the molecular tumor boss, we identify the therapy that will be used for the patient. Of course, we identify our conclusion. When we look at the cost of the Human Genome Project, it has changed over the years, and now it has been reduced to $1,000. Our target is to reduce the cost to $100, and it is estimated that this target will be reached in 10 to 15 years. There are different components which affect the cost, such as the data processing or using the kits that are costly, or the cost of equipment also affects the final cost. And it is our target to reduce these costs, especially in Africa and Middle East. Human genome data is not available for the entire world to benefit from this system. The data should be collected from different parts of the world, and the genomic variants should be available so the markers are identified. In genetics of cancer, we use some sources, and these are precision oncology knowledge bases. We use different databases so we can make clinical interpretation of somatic variants. And there are sources of NGS industry. Some of them are open to public, and some of them can be used by specific organizations. We usually use OncoKB, and there's also another one created by NIH. And there are knowledge bases that are approved by FDA, and we can be sure that such data is significant. You don't need to double check or question the reliability. So, FDI question systems, Klingon and OncoKB are FDA-approved systems that are reliable. And there are some systems that integrate the knowledge bases that I may not have included in the previous slide. And there are integrated knowledge bases. There is the variant interpretation for Cancer Consortium meta-knowledge base, and you can access these knowledge bases to find out if there's a recent clinical research in the area that you're interested in. Clinical variants. Data on clinical variants are available, so they are based on machine learning, and they alter their own systems as more variants are added to the system. This system that I show you on the screen works on Amazon system. When we evaluate the variance, we use standard operation procedures developed by ClinGen, CGC, and VICC. There must be specific criteria so you can identify whether what you found in the lab is benign or malign. So on this scale, pathogenic, oncogenic, or insignificant, benign or non-benign, on the scale we identify 1 point, and we also use the literature reviews. There are abstract books, and NIH has recently introduced a genomic data portal that was introduced recently. In the first stage, it may not be possible to reach a conclusion with the algorithms that we used, but in order to simulate what kind of implications may develop, we use the computer algorithms, and we identify the isolation analysis. We do the isolation analysis for the region. So we identify how the genomic structure is changed by the environment. And we also use the estimation algorithms. In addition to these, artificial intelligence mechanisms are very popular in identification of cancer. Depending on the type of cancer, there are new applications that may provide you with findings. And in reporting, we use FDA-approved treatment types, and we don't include unreliable variants in our report. Thank you for your presentation. We have concluded our session. Thank you for your attention. Thank you all. Have a great evening. I think we will go to dinner. All guests.